welcome to the people from the country areas and from interstate. I know there's quite a few of those, and I'd like to welcome the various team leaders of the self-help group. If I could just take a moment out and get them to stand one by one as I call the names so you can acknowledge them, as they do a lot of hard work behind the scenes, and I think it's pretty important that they be recognised. From Canberra we have Carol Tony and Barry Telfer. You could... Thank you. From Lismore we have Jeff Gagan. From Tamworth, Kathy Challinor. From Taree, Helen Kramer. And from Parramatta we have Bert Staines. I'd like to start off by asking a simple question: why are we here? And I think the answer is that it's a problem that affects so many people. It doesn't matter what walk of life they come from, different ages, different groups, whatever it may be. It's a problem that affects us all. I believe one of the frustrating features of tinnitus, and I think sometimes the most frustrating feature, is you can't see it, you can't measure it, you can't feel it. But I know that people that have got tinnitus, and I'm a sufferer myself, we can certainly hear it. So hopefully today we can go down the path of learning a bit more about it and maybe learning how to cope. Now, the aim of the Beyond Silence Forum today is to educate, better understand, and able to cope with this affliction. We will hear about the different causes of tinnitus and how prevalent tinnitus is in the population. We will hear about current treatment strategies, hearing devices, and the very important psychological impact of what it has on people. This is a get-together of sufferers, clinicians, hearing specialists, and people who devote so much time, many on a volunteer basis. This is why I know that today will make a difference. Now, I'd like to just get through some housekeeping matters, if I could. We've got a lot of people here today, and so time is of utmost importance. I would like to keep the schedule running as the program. So after the breaks, possibly a few minutes before the speakers due to start, if we could make our way to our seats, so we keep on schedule. Of course, mobile phones, if anyone's forgotten to turn them off, please do so, because that will affect the recording, and we are videotaping the day. And there will be a brief opportunity to ask questions after each speaker is finished. I say brief. If you've missed out, there will be another opportunity after the session, so after 3 speakers. If again you've missed out, I invite you to write down the questions on a piece of paper, which I think is provided in the satchels you've got today, and hand them in to one of the ATA organisers, and we'll endeavour to answer them and put them down in the newsletter, which we've published shortly. At this point, I'd like to introduce Dr. John Tonkin, who's the patron of the ATA, and he will officially open the forum today. And then following Dr. Tonkin, Professor Bill Gibson, who will be the chairperson, he'll give a few words. So thank you very much, and I hope the day will be very rewarding for you.
Good morning, ladies and gentlemen. Looking at this audience, it's quite amazing. The entire auditorium is full, and I'm told that an equal number of people applied to come this morning and had to be refused. As Frank says, the reason for the interest in this symposium this morning is this complaint is so common. So the symposium today, or the talks today, will try and track some of the progress being made towards finding out what causes tinnitus and what can be done about it. I'm going to start my talk this morning by talking about the tinnitus of Meniere's disease and where we've got to in understanding Meniere's disease and how tinnitus can be helped in Meniere's disease. And I hope to show you that there is a new modern treatment for Meniere's disease which offers great progress, great hope. Frank mentioned that he had tinnitus, and I know how he got his tinnitus. And I myself have tinnitus. My tinnitus is beautifully controlled by a CIC hearing aid, a digital hearing aid in my left ear. Now, to me, that's been a great advance. And for many of you I know here, or for some of you, have been chary about wearing a hearing aid for their tinnitus. And if you haven't tried a hearing aid for your tinnitus, you really must do so. The new digital hearing aids with the new beautifully controlled method of measuring your hearing loss and measuring the hearing aid to match that hearing loss has made immense strides in the last few years, but especially, I believe, in the last 18 months. The computer programs are much better. So let's have the first slides, and we'll talk about the tinnitus in Meniere's disease. Now, touch screen to activate. Press on slides. I'm sure that's what I'm supposed to do, but I had this problem before. Where are you, Warwick? There you are. Where's Warwick? There, Warwick. I press slides, and then I press Garvan Institute. Warwick. Turn it on. Thank you. Thank you. All right. Now, good. Now, we've got to have a little bit of physiology this morning. We've got to have a little bit of physiology because it's so important understanding where we're going in tinnitus in Meniere's disease. Now, I think I've dropped it. No. Anyway, in the middle, you can see that enclosed triangular space, which is called the scala media, or cochlear duct. Now, this is an important factor. Along the side, there's a rich vascular structure called the stria vascularis. Now, the stria vascularis, thank you. The stria vascularis has a function of controlling the sodium content of the fluid in the middle of the scala media. It actually takes sodium out of the fluid, just like the renal tubules. The renal tubules in our kidney take sodium out, and that's called the sodium-saving function of the convoluted tubules. Now, interestingly enough, years and years ago, when I was a very young doctor, there was a histopathologist called Catherine Smith, and she used to show at meetings slides, one showing the convoluted tubules, the other showing the cells of the stria vascularis. And she'd say, now the one on the right is the stria and the one on the left is the convoluted tubules. And then she'd turn around and say, oh no, I think I've got that wrong. I think it's the other way around. And she did it deliberately, of course, to show us, we mere clinicians, that you can hardly tell the difference between the two structures when seen on the microscope, seen under the microscope. Now, that, of course, that knowledge has been there, lurking in the background all these years, and it is a fundamental piece of knowledge, as we'll see in a few minutes. Now, the next slide, I'm going to show you there's a slide where a patient with early Meniere's disease in the right ear, normal hearing in the left ear, and a low tone deafness on the right ear. Now, these nice slides were supplied to me by Celene McNeill, and they're your slides, Celene. At this stage, the patient may have fluctuating tinnitus. The tinnitus may only really be there troublesome just before an attack. Now, there are some people who mainly have tinnitus as their complaint in very early Meniere's. Not common, but it does happen. Now, the next slide, here's a patient with stage 2 Meniere's disease, more advanced, more serious deafness, tinnitus probably all the time, but maybe rising to a crescendo just before an attack. This, of course, is diagnostic of Meniere's disease, this fluctuating hearing loss accompanied by fluctuating tinnitus. There are patients who will get an increase in their tinnitus without an increase in their hearing loss, but commonly they go together. And most patients will know that they're in for an attack when their tinnitus starts to increase. Now, third stage Meniere's disease. At this stage, as a general rule, the tinnitus is persistent, doesn't go away, maybe doesn't fluctuate much. The hearing is no longer fluctuating much. Not quite, or maybe reaching the burnt out stage where the patient no longer has any attacks of vertigo, but their major complaint is tinnitus and deafness. And of those two complaints, the most worrying factor is their persistent, disturbing tinnitus. This patient is pretty lucky that they only have it in one ear. And until now, beyond benzodiazepams and other things like that, there wasn't really much you could do for that tinnitus except supply a good quality hearing aid. And that would help even at this stage. Now, the news about gentamicin in Meniere's disease is not really new. I mean, I did do it years ago, 12 years ago, in fact, when I did a series of 12 patients. But the doses we used then were very much larger than the dosage that we use now. And as a result of that, nearly all the patients, although they may have got rid of their attacks of vertigo, became fairly ataxic because you had knocked out, pretty well knocked out, the labyrinth on that side. And in lots of people with Meniere's disease, as Professor Gibson has shown, that even if they have no actual signs and symptoms in the other ear, do display many of the criteria, the incipient hydrops in their good ear. And of course, as you know, a proportion of people do develop Meniere's disease in the other ear, and some unlucky people have bilateral Meniere's disease from the beginning. So it was that reason that stopped me using gentamicin these years ago. It was revived in Scandinavia, although I'm not sure whether the Germans ever really dropped it. The Scandinavians, particularly in Norway, began to use much smaller doses and reported brilliant results. So I was interested in doing it again and took it up and did, for first of all, tried to imitate the Americans by using a small catheter to deliver a small, tiny, steady dose of gentamicin. But there are various factors against this. One is that the catheter itself is disposable and costs $1,800 American dollars. You had to have a pump that would deliver a steady dose, and this cost many thousands and thousands of dollars. And in the Australian setting, it was impractical. I had a friend in New York called Silverstein, and we used to meet at odd clinics, and I told him that I couldn't afford the pump and that I was going to put a piece of gel foam in the round window niche and soak that with gentamicin. He looked at me and he said, "That's exactly what I'm going to do, and I have actually started to do it." I said, "Oh, how's it going?" He said, "I don't know yet, but I'm going to try it." So I did, starting in about April of '99, I've been using gentamicin, and I'll show you how I do it. Now, intratympanic gentamicin. You can, if you like, put the gentamicin into the middle ear via a needle penetrating the tympanic membrane. And I know at another hospital across the city, this technique is used, flooding the middle ear with a large dose of gentamicin, say 40 milligrams, and with very good results. Now, I want to show you this little bit of anatomy of the middle ear, where the middle ear is cut across, displaying the round window niche, and you can see there's that little thin membrane, which we call the round window membrane. Now, we were assuming that our gentamicin would pass through this membrane. So what we did with the consent of the patient, in a patient having a acoustic tumor surgery, we put some gentamicin on gel foam and placed it in the niche. These people are going to have their whole cochlea removed because they've got a tumor. And we then, after 5 minutes, extracted some perilymph from the basal turn of the cochlea. And we showed that the gentamicin had passed straight through the round window membrane and was present in the perilymph in suitable concentrations. And we did this twice, and each time we got the same good result. Now, following on that work, a registrar who was with us at the time, called Dr. Zoran Bekarovsky, carried on this work when he was in the United States at the Michigan Ear Institute. And he did quite a few cases and presented his results at the American Academy meeting this year, and it was so well received that he received the prize for the best registrar talk at that meeting, which is a very prestigious honor. We also have used other substances such as Decadron, etc., and we have similarly found that passes through the round window membrane very easily. Other substances such as nerve activating factor, etc., are also being proposed to be used. Now, in other words, when we put the gentamicin in, it goes straight through into the basal turn of the cochlea, and hence around into the fluids of the vestibule, and then into the labyrinth. Now, the dose that I have been using is 4 milligrams, which is a tiny dose. And in fact, in several cases recently where I've been a little concerned as to the effect on the labyrinth, I've only used 2 milligrams. And 2 milligrams, to my surprise, seems to have an equally good response as 4. So I think in future I will probably only use this tiny dose. Now what happens? Why does gentamicin work? Well, it's become very interesting. There's been some discoveries made. A research team in Denmark, in Paul Bretlau's laboratory, they have found that there is a secretion from the cells of the saccus endolymphaticus of a hormone, a protein, which they called saccharin. Now, I just wanted to read to you from that, if I can find it. They're little tiny bits from their articles. Did I drop something, Frank? Oh, it's down there. Sorry, there it is. Thanks, it'll be there. Thank you very much. Now, this is very interesting. Very interesting. Because I'll quote a little bit. This is an article from the American Journal of Physiology, a most prestigious journal, entitled "The Inner Ear Produces a Natriuretic Hormone," from the Department of Medical Anatomy, University of Copenhagen. Cytoplasmic granules have been demonstrated in epithelial cells from the endolymphatic sac, an osseous part of the inner ear located in the posterior cranial fossa. Now listen to this. Intravenously infused extracts from endolymphatic sacs in anesthetized rats elicited a potent natriuresis and diuresis without affecting the blood pressure, glomerular filtration rate, or lithium clearance. Only a minor potassium effect was observed. Extracts of dural tissue adjacent to the endolymphatic sac produced no effect. Concluded that the endolymphatic sac contains an endogenous source of sodium resorption and could be the sensory organ mediator of central natriuresis. Furthermore, this substance, tentatively named saccharin, may influence the homeostasis of the inner ear fluids and accordingly play a significant part in the pathogenesis of Meniere's disease. Now, I consider that this article is the most important article published since Meniere's original article in 1861. At long last, we have the clue as to the cause of Meniere's disease. There has been an overaction, an oversecretion of saccharin, which inhibits the cells of the stria vascularis, inhibiting their function of sodium resorption. Hence the sodium content of the scala media rises, fluid passes across Reissner's membrane and produces eye drops. That is Meniere's disease. So, let's examine that little tiny thing which I made a further article, but in further work in Bretlau's laboratory. A previous investigation indicated that the chief cells of the endolymphatic sac produce an endogenous inhibitor of sodium resorption in the kidneys has been tentatively labeled saccharin. In this study, the ultrastructure, that means the appearance under the microscope, the ultrastructure of the endolymphatic sac, in particular the chief cells, is described, demonstrating this organ fulfills the morphological criteria of a potential endocrine organ. Accordingly, the chief cells are shown to exhibit, listen to this, all the organelles and characteristics of cells that simultaneously synthesize, secrete proteins. Saccharin is a protein. Gentamicin has been known for years to exert its antibiotic function by inhibiting the synthesis of protein. So the gentamicin we have been putting into the inner ear has inhibited the secretion of saccharin. So we have restored homeostasis of the inner ear fluids. Now, at long last, we have the molecular basis for Meniere's disease. We know how it happens. Now, let's go on. Now, this is my first 23 patients. I've now done over 40, but immediately I got an extraordinary control. I had 2 failures. That's the hearing result. Was better, the same, and only worse in 4 out of the 23. Now, here's the thing I want to talk about. I don't know how to explain this. These people, most of whom had quite severe tinnitus. And I remember the early cases I operated on were very severe Meniers. I mean, I didn't like to treat people with moderate or slight Meniers. I only treated severe. And look what happened to their tinnitus. I'd only failed to suppress it in 1 case. I don't know what's happening. I can't tell you why this is such a brilliant success. Maybe it won't continue to be as good as it is. Maybe my early patients, maybe I was very lucky. But it certainly is the first time I could say to my patients with Meniere's disease, well, there is a good chance that we may be able to relieve your tinnitus if you have Meniere's disease. And the results speak for themselves. Now, those people with partial compression or partial abolition, that should be suppression, not compression, tell me that it's still there, but it no longer worries them. It's pushed into the background. All right, now let's try and get some explanation. Presumably, if you restore homeostasis to the fluids of the inner ear, there is an improvement in the physiologic function of the hair cells. Maybe we have stopped the excessive entry of calcium into the interior of the outer hair cells and maybe even the inner hair cells, thus inhibiting the alteration of the electric currents both outside and inside the hair cells, which is thought to be the reason why you have an excessive production of neurotransmitter, which causes tinnitus. Now, this is theory. I don't know whether this is the case. But something has happened. Something has caused these people to have a very gratifying reduction in their tinnitus. Last case, I'll just show the hearing of a professional lady. As you can see, she's got bilateral Meniere's disease, and it does fluctuate. And it reached the stage, she didn't seem to be able to wear a hearing aid very successfully. Everyone tried. And she asked me, after hearing me talk, could she have it? And she got, that left ear is now her good ear. That's the sort of hearing improvement that is extraordinary, and it has lasted. She has not had a single attack of vertigo. She has no tinnitus, and her hearing, as you can see, is extraordinarily better. Now, in a few cases, I've had to do the operation twice. But on the second occasion, knowing that there was no fibrous tissue occluding the round window niche, I was able to do this in the office with a very fine needle and put in 2 milligrams directly into the inner ear. Silverstein says that in 20% of cases, and I agree with him about this, the round window niche is covered over with a membrane, so that if you just put the gentamicin into the middle ear, in 20% of cases, it's almost certain to fail. So that's why I lift up the edge of the eardrum and put my little pledget of gel foam into the niche and then soak it with 2 to 4 milligrams of gentamicin. Now, I think Professor Gibson has a technique where he actually inspects the round window membrane with a... Would you still do that, Bill? Yeah, he still does that. He inspects with a very fine endoscope the condition of the middle ear, and he could see whether or not there was a membrane covering it. And lately, Silverstein has used this technique where he makes a little tiny nick in the eardrum, uses this endoscope, and he then uses tiny hooks if there's a membrane covering it, and takes that away and then puts the gel foam in. It's a real fiddle, and it's much nicer for the patient to just have a little tiny flap elevated, the gel foam put in, a pat on the head and say that you can go home now. They don't have to stay in hospital. They don't have to have a full-fledged anaesthetic. They can, it takes a little while. All these things, sometimes the condition is such in Australian ears, especially in the men, that they've got a little mild degree of exostosis formation. That is to say, it's a swelling of the bony canal due to swimming. Now, if you've got that, you have to have an anaesthetic, because that bone has to be drilled down in order to lift up the edge of the drum. But these are little things that happen in ear surgery. We're used to little complications like that, and we can advise our patients what we can do. Now, so far, the people who've had this condition have got a definite reduction in their balance organ, but it seems to improve with months, or weeks in some people, young people, but in months in older people. And they need to have, or at least quite frequently need to have, rehabilitation exercises. And this is not onerous for them, and it improves and improves as a general rule. I only have one patient at the moment who's got persistent ataxia, and it affects him when he bends forward to play bowls, and that's a great disability for him. In all other respects, he's all right, but when he leans forward to play, he feels as though he's going to fall onto the green. And I said, "Is that awful?" "Oh, no," he said, "it happens nearly all the time at bowls." I suppose a lot of people do, but he's a fairly young man. He's only about 58, so he thinks that's a bit wicked. Now, when we test him, we find that he has a reduction in the capacity of his saccule. His semicircular canals, so far as we can see, are perfectly all right. And I thought I found this a few times, and I was interested, so I rang Michael Hallam and said, "Michael, what do you think of this?" He said, "Oh, the French know about this. They've written it up already, that the saccule is more sensitive than the semicircular canals to gentamicin." And I don't know that there's anything one can do about that. Maybe I might even reduce the dose to 1 milligram. I might try it. Now, I haven't given this treatment to people with normal hearing. They have in Denmark, they have in Switzerland, they have in Sweden. Michael Hallam informs me that they have done it in people with normal hearing who are having persistent tinnitus and fluctuating vertigo. Now, it was a very, very early Meniere. The next time we have a meeting here in this institute, I hope to be able that I'll tell you the results of my doing it in people whose major complaint is tinnitus, who only have tinnitus as their presenting symptom, and very little of any vertigo and hearing loss. Now, they do occur. They do occur. Now, one thing I'm not sure of, and Professor Gibson might comment on this later, in those people with tinnitus as their major presenting sign, do they have a positive EKG? Or could they have? If that were the case, and it showed that they really were suffering from high drops, maybe we could give them a small dose, say 1 milligram of gentamicin. Now, the reason why you have to do this, we have no experimental animals. In which case, our patients become our experimental animals. We have to say to them, are you willing for us to try this? And for some people, the majority say, oh, look, I really wish you'd try. But I haven't done it because I'm being held back ethically. There's nothing so formidable as facing an ethical committee of 20 people, most of whom are not doctors, and they say, is Meniere's disease fatal? You say, no. Could the patient go totally deaf from 1 milligram of gentamicin? And you say, well, maybe, I've never heard of it, but maybe. Well, do you think you ought to do it? Well, that's the end of it. So at the moment, I can't do it. All right, well now, I think that, will we take some questions now, Frank? Would you like to share the question and answer?
Well, thank you, Dr. Tonkin, for, I know for me it was an introduction to Meniere's. I really didn't know very much about it, so it's taught me quite a few things. I'd like to introduce Professor Bill Gibson, who comes from Royal Prince Alfred Hospital, who, as I mentioned earlier on, is also the chairperson for today. So thank you, Bill.
Thanks, Frank. Thank you for inviting me. I guess if we counted up all the decibels that this room would produce from the tinnitus, we could lift the roof off. It's great to see so many people here. John's given a very thought-provoking talk, and I'm sure he'll take some questions now. It's interesting what he's shown. Obviously, the treatment he's giving is to reduce the fluid in the ear in people who have Meniere's disease, and this seems to have had an effect on their tinnitus. Whether or not you could use the same treatment for somebody who doesn't have tinnitus, I think that's a bit, doesn't have Meniere's, might be a bit dubious. I'll ask him. He's mainly gentamicin for Meniere's tinnitus rather than people with
yes. Look, we've got to make that quite clear. You better say. This is for the tinnitus and Meniere's disease. Ordinary tinnitus, non-Meniere's disease tinnitus has not been tried with gentamicin. In fact, I can't see theoretically that it could help.
So I just thought I should make that clear. So would anybody like to ask? One question, how long does that single application of gentamicin last?
Well, the first cases have now been done over 2.5 years. If a patient has to have it done again, it's usually fairly quickly. It's fairly quickly demonstrated that the first application has not been totally successful, like about 3 months later, etc. But the vast majority of people, of those 40, one application seems to work. And I don't know why that should be so. I really don't. One of the things that the great challenge for us now is to find out what regulates the secretion of saccharin. We know that the endolymphatic sac is supplied by branches of the external carotid artery, which has sympathetic and parasympathetic fibers in the vessel wall, and that these control the supply of blood to the sac. Now, whether it's the blood supply to the sac that controls the secretion, whether it's a direct nervous connection to the cells, or whether there is another hormone secreted by the anterior lobe of the pituitary. I mean, we're looking at something analogous to the thyroid gland. Hypersecretion of thyroxine causes horrendous symptoms in the body, but the control of thyroxine is by no means totally known, even today.
anybody else with a question, ask Frank or bring you a microphone so that everybody can hear the question up the back.
Excuse me, could you tell us the difference between tinnitus and Meniere's disease?
Tinnitus is a symptom whereby we hear a sound when there's no external sound. So you hear a sound like cicadas or an electric sound or whatever. And so it's a symptom, and it can be caused by a number of different diseases, which I'll mention this afternoon. I guess the commonest is noise exposure nowadays, too much noise damaging the ear. Amongst all those different causes of tinnitus, we have Meniere's disease. And Meniere's is a condition which causes 3 symptoms: attacks of devastating vertigo, where people spin and get dizzy, ringing in the ears, sense of fullness in the ear, and a hearing loss. So there's 4 symptoms, and it's one of the causes of tinnitus. Probably about 1 in 1,000 person in the population does have Meniere's disease and suffers from tinnitus because of this.
Good. You had another question, Bill?
How do you get diagnosed against tinnitus and Meniere's disease? Do you have to go to somebody like you? Or, because I've been diagnosed with tinnitus and I didn't know it was related to Meniere's disease.
Well, it probably, if you haven't had those other symptoms like attacks of vertigo or fluctuant hearing loss and blocking and fullness in the ear, you probably haven't got Meniere's disease as the cause of your tinnitus. And, well, the first thing you should have is an audiogram. You should have an examination of your ears, then you should have an expert audiogram. And that's the first step in trying to diagnose the cause of your tinnitus. And of course, a physical examination is necessary as well. So you really need to see a good ear specialist, have a really good audiogram, and the course of treatment is usually decided between the otologist and the audiologist. Is that all right? Good. Yes.
Doctor, the drug memantine, which came out in roughly about the end of 1999, has there been any progress with that at all for tinnitus?
Well, I know that the clinics in Europe definitely seem to be proceeding to use it. They've used it in San Diego. We can't use it here in Australia because the federal government has not approved of its use, and I don't see them ever allowing us to use it. And there are several other drugs like that are not approved. I haven't used it. Now, we haven't used it at St. Vincent's, hasn't been used at Prince Alfred, even experimentally, because it's not cleared for use in this country. My personal view is that that's purely a financial decision on the part of the federal government. Nothing to do with medicine. Well, I suppose we ought to go and have a morning tea now, don't you think?
If we could all be back about 5 to 11, and we'll start the next speaker at 11. Thank you.
I thought everybody's here. I thought we might as well start. And I'd like to introduce Tony Crittenden, who is the audiologist who works at Concord Hospital. And he really is one of the pioneers of tinnitus retraining therapy. And he was one of the first people to start it here in Australia. Tony.
Thank you, Bill. Thanks very much. Thank you. The topic for today is tinnitus and the veteran, and I'll quickly toggle this back to the start. That's the start, silence. White noise, whatever. It occurred to me that I should quickly define tinnitus, and I've got nothing written down here, but I think it's awfully important to make it clear that tinnitus is not a disease. People often, I've heard somebody say today, I've been diagnosed as having tinnitus. Well, tinnitus is something that if you are acting under the misunderstanding that some people have it and some people don't, forget about it. Everyone's got tinnitus. That was proven with research in the mid-50s. And everyone's ears make a bit of noise. If they didn't make a bit of noise, we'd probably not have normal hearing function. We're talking about distressing tinnitus when we talk about it as a disorder that requires therapy. Now, the other thing I must say, Dr. Tonkin spoke about a disease that has, as a co-symptom, amongst other things, well, Meniere's disease, the primary symptom, the most distressing would be the vertigo, the dizziness. But that's a case where there's a very strong physical association with the disorder. But in the first instance, it would be unfair of me to say, well, look, you don't need to go to a doctor if you're troubled by tinnitus. I think see a doctor and have it checked out medically. And then if there's nothing physical, medical that can be readily done about it, then you look for other strategies to follow it up. The other thing I want to say up front, because I guess it's the takeaway message, I'll be talking about veterans where they've obviously been exposed to noise and this has damaged their hearing mechanisms, and associated with that they've developed tinnitus or intrusive tinnitus. The other thing I am very concerned about in the modern world is the number one cause of tinnitus has to be noise-induced hearing loss and associated tinnitus, noise-induced tinnitus, and it's the number one preventable cause. And we haven't bitten the bullet with controlling noise, both in public places and educating people not to zap themselves with excessive doses of recreational noise. And when you think back to how we used to all sit out in the sun all day and get sunspots, and now what we do to prevent it and protect our children, we've got to do this with noise exposure. So that's sort of the lead-in message. The essential topic for today, the key topic, is tinnitus in the veteran. I'll kick off the little slideshow here. On the home version, there were a few little sound effects that went with that, but they're not really too important. I'll be talking about briefly about a model, an explanation for how tinnitus becomes a problem for people. Now, I must emphasise, I'm not talking about hearing tinnitus, I'm talking about the thing worrying you. And we follow a model at Concord that goes by the long-winded name, the neurophysiological model. Now, I don't want to get bogged down here, but we're talking about phenomena that people experience. Tinnitus isn't something you can look at under a microscope. You can't measure it in any satisfactory way, but it is nonetheless a physical condition. So I'm not talking about people having some sort of emotional disorder. That it begins with a physical signal, presumably understood to have originated in the cochlea, and then it's transmitted to the brain by nerves, neurons, and experienced in the brain and through the brain, as we experience everything through our brains. So you'll see this model referred to, and you will hear me perhaps refer to it as the NP model, or talk about two characters who developed and publicised through the literature the model: Jonathan Hazel, a British ENT specialist, and Pavel Yastreboff, a neurophysiologist in Baltimore in the US, who have both collaborated and more or less have an international centre across the ocean, so to speak. At any rate, we first became aware of this approach to tinnitus and the implications it would have for understanding people suffering from tinnitus and how to help them better deal with it. In my case, in the 1990s, 93, when Ross Coles, an eminent ENT from the UK, came out and he gave an interesting set of lectures over at the National Acoustic Laboratories that some folks here would have attended. And I first heard about the work of Hazel and Yastreboff, and I became aware that it seemed to make a lot more sense of the fact that any number of us can be aware of tinnitus. I'm certainly aware of it. I'm not particularly aware of it in here because of the acoustics, but I'd be aware of it if I'm sitting at my desk at night, that type of thing. I'm not a sufferer because most of the time I could basically flick a switch and not listen to it. But it's there if I want to, but usually there's no good reason to want to listen to it. And I'm sure many of you would reinforce that thought. Our experience in applying this approach, and I'll try and flesh it out a little bit, was that it actually made a lot more sense of why some people seem to have hang on to the problem, not be able to move on from it. And so over the last almost 10 years, I guess it's reinforced our belief that it is the most satisfactory model for explaining the intrusive aspects of tinnitus, why it makes people unhappy and causes suffering, and it's continued to guide our therapeutic approach. One of the things that got me interested again in veterans suffering from tinnitus was the work of a clinical psychologist, Dr. Robert Apathy, who is based in Canberra, and he approached us via the ATA for information about the neurophysiological model because he'd been reading about it in the literature. He'd been looking long and hard to try and find out why so many, over 90% of the veterans who reported presented with the condition were diagnosed as having post-traumatic stress disorder, which is a very common post-battle syndrome. It used to be perhaps called shell shock and whatever in previous wars. He was trying to find something that made sense of the fact that so many of them seemed to be, amongst all their other symptoms, have this problem of noises in the head. And he felt it was more than just having been exposed to a lot of noise and some of them having hearing loss. Because in amongst the group, there was at least a third of this group of about 90 people that had normal or essentially normal hearing on audiograms, and many of them hadn't really been exposed to extensive noise exposure, though that would be hard to verify. But our hypothesis was that this extremely high prevalence of tinnitus distress, and I emphasise the word distress from tinnitus, not experience of just hearing the noise, that it could not solely be attributed to ear damage to the cochlea and the inner ear. Robert Apathy also noted to us that he found the group, this veteran group, were very resistant to therapy in general. They were almost all Vietnam veterans. We were very interested in the writings and publications of Pavel Yastrabov and Jonathan Hazel. What they basically were focusing on was the fact that powerful emotional forces may underpin the onset of tinnitus distress and not just the damage to the auditory mechanism as previously proposed. So we're looking at beyond just the damage to the cochlea, looking at emotional states and involuntary autonomic responses, reactions to threats. Two pieces of information that are put forward in support, and we've certainly found this to be the case. Most people, when they talk about their tinnitus, will tell you the background to when it started to worry them. And so often, the factors that really triggered the thing off, the so-called trigger factor, was something entirely unrelated to the ear. We think it's about 80% of cases. There's some other psychological crisis. Now, I must again pause and say I'm not talking about somebody with a straight-out psychological emotional problem. I'm talking about somebody who's got physiological damage to the ear or presumed damage to the ear. So there's a source of signal, there's tinnitus nerve impulses, spontaneous activity in the inner ear that the brain is hearing and recognising as some sort of sound, but it's not a sound outside. That's the sort of potted definition of tinnitus. But about 80% of people have some other life event. They've had a bereavement, they've had a son on drugs, they've had their wife or husband leave them, they've perhaps been retrenched. That's not an uncommon one amongst industrial workers. They're at home after being on the job for 20 years and they're sitting at home worrying about their plight, and they've got damaged ears and they start hearing the noise and the thing sets up a vicious cycle. In Hazel's study, 1994, he studied 100 consecutive cases and 75% of his patients had a non-ear related problem of the kind I referred to. The other thing that's of interest is that there's no direct link between the degree of distress as reported by the patient or measured by questionnaire techniques between the degree of deafness, so the loss of hearing, say in decibels, and the extent of the problem. And we've certainly found this to be the case. Some of the worst cases of tinnitus from a disturbance and a distress point of view seem to be people who have essentially normal hearing. In other words, the peripheral mechanism, the slides of which John Tonkin showed you, the inner ear, that's all working fine as best as we can judge. And in other cases, people with severe hearing losses, where we could assume that the inner ear has been damaged extensively, they may be experiencing tinnitus, but they're not particularly distressed by it. So in the case of veterans, we come to the concept that it wasn't just the big bangs that caused it. And I'm talking about not the experience of tinnitus, I'll hammer this right through, but the actual distress or suffering that the patient or the individual suffers. And it's obvious with veterans that they've been exposed to a life-threatening situation, obviously, and their whole emotional system in a combat zone is on, as it were, red alert. And it's this heightened sense of awareness and alertness and self-defense that probably, we think, makes the individual more vulnerable to the onset of intrusiveness of the tinnitus signals. Now, undoubtedly, many of them have noise-induced hearing loss, and undoubtedly they were exposed to noise in most cases. In the case of a Vietnam veteran, the sort of situation they encountered was different from the Second War veteran, which is the other big group that we've seen many of in the clinic. And I'll put in one bit of information that I learnt this week from the Vets Association. The average number of days of operational combat duty by a Vietnam veteran was 250 days. The average number of days of a Second War veteran of combat duty was about 30 to 50. And it seems almost mind-boggling, but it was a different conflict, and it didn't apply, of course, to all areas of the services in the Second World War, but on average, a lot of people served that they weren't in continuous life-threatening situations. For one thing, they always had to be shipped from A to B, and that took a hell of a long time. So the scenario is war dramatically heightens one's arousal system. Comparable extreme situations are certainly found amongst the civilian population, but probably not as frequently, and I'm thinking of accident cases and other traumas. War is certainly noisy, and inherently it will cause damage to the inner ear. But to repeat again, the experience of tinnitus, the perception that I've got some noises in my ear or head, has to be distinguished from the intrusive condition whereby you are worried by the condition, distracted by it, can't get your mind off it, and your quality of life thereby suffers. The long-term emotional consequences of exposure to horrors of war we now call post-traumatic stress disorder, and tinnitus distress is certainly a very common co-symptom of this condition. There was a little sound over somewhere in there. It's gone. The other thing that we've found is that Vietnam veterans, for example, react differently to therapy, and the condition seems to perseverate, hang on, exist for a longer time and be resistant to treatment. We've got our ideas about why this might be. In the case of Vietnam veterans, we think undoubtedly the alienation that many of them felt when they returned from the war, and that wasn't remedied for a long time, just as we still haven't remedied the Aborigine situation, but that is detouring. They have therefore tended to persist in the suffering mode, these Vietnam veterans. Now, in the case of the Second War veteran, the problem was often ignored and not treated or badly handled for many years, but interestingly, and I've got some results to showed this. The Second War veteran reacts to therapeutic activity in much the same way as a civilian, a general citizen. So on the one hand, the Viet vet was exposed to noise, but he was involved in some people call a dirty war, where many of the society that he was representing didn't support him. They came back and were alienated and so on. So there's a huge additional and compounding emotional component which entrenches the tinnitus and other somatopsychic conditions, that is where a condition in the body has an impact on how you're thinking. We talk about psychosomatic disorders where you can develop a rash because you're anxious. Well, there are mental and psychological responses to bodily things, and I guess in some ways tinnitus distress fits in with that category. The Vietnam veteran particularly is reluctant to trust authority, and that could be doctors and counsellors, could be police, whatever. And this is a broad generalisation. But somebody who has been exposed to that trauma and suffer the post-traumatic stress reaction is likely to have blocked off the sort of side door access of therapy. Now, one thing we've found with tinnitus clinics is that it's not a direct, logical sort of process. It's not a thing that you operate directly on the conscious cognitive activity, the thinking patterns of the patient. It's not like going to the physiotherapist and he says, yes, you've got a sprained ankle, we're going to put you through this, this and this, and at the end of it you'll come out with a functioning ankle and you'll be able to take up tinnitus again. And that's where this concept, we hear the word tinnitus retraining therapy, and it has the connotation in people's mind that we're putting them through some sort of a physical model therapy, and they'll pop out the other end without the problem. It's a subtler thing than that, and that's why it's more of a challenge for both patient and therapist. The presence of other health problems doesn't help. And of course, a lot of these people do have other ailments, and the deafness, the hearing impairment is often a significant part of it. Others will be talking about the therapy aspects of for tinnitus patients later. So I'll confine a little bit of the next section. I'll just abbreviate a little bit. The challenge for us as therapists is to help a group of people who are resistant to therapy. We've in a way got to get them to accept the possibly good news that the brain processes which underlie their tinnitus distress are to some extent plastic and modifiable, and that it is possible to gradually, and this will take no short period of time, to move beyond tinnitus in living their lives. So we in a way have to sort of do if you like, call it brainwashing session. We have to redefine the problem for people as not being simply the presence of the noises in their ears or head, but rather their inability to tune out from the noises. And we think in the case of these veterans, particularly the Viet veterans, it's because of the entrenching effects of powerful emotional forces. Very briefly, in terms of therapy, the sort of things we do in so-called directive counselling is try and give the patient a chance to explain their problem and how it came about and circumstances in their life. It's a thing they don't often get the chance to do. And we have to recognise individual differences amongst people, even though we do much the same thing for everyone, whether they be veteran, community patient or whatever. I mean, in the end, we've got to recognise everyone is an individual. And in the case of Vietnam veterans, we probably have to be aware of other coexisting conditions if they're suffering from depression. And in our case, we're not competent to deal with that. We call upon our expert professionals in the medical field to help these patients. We have to stick to our territory, and part of it's an informational thing, trying to demystify the concept of tinnitus for people. I mean, as I say at the outset, it is not a disease. It literally comes from the Latin word which means ringing, but it's been generalised in its application to mean any sort of phantom noise that you experience. It's not caused by an outside sound wave. We've got to demystify, we've got to explain how the hearing system works, we've got to clarify for the individual why their brains and emotional centres are involved, and get them then to do the hard work themselves, which is to make behaviour changes in their lives which will have a spin-off benefit of making the tinnitus far less intrusive. And this includes lifestyle changes and, above all, some form of serious attempt to deal with stress. We liaise obviously with psychologists and other counsellors. We try and do what we can within an audiology clinic to provide people point them in the right direction, give them tapes on stress management, take them through simple day-to-day strategies for improving their life situation. Sleep problems are vital. We have to try and work with them, and for some people it may require medication, for others it's just getting their life organised and be sensible about planning their sleep. Ear-based therapies will be spoken of in more detail later. Hearing aids are crucial. John Tonkin's cited his own example and the many others of well-fitted and adjusted hearing aids for people with significant hearing loss, getting appreciable reduction in their perception of their tinnitus. Above all, we've got to overcome the nothing can help me syndrome before we go forward. Dr. Apathy, the psychologist I referred to, he's very interested in using biofeedback techniques to deal with stress control. There's a body of research which demonstrates that once you reduce stress and physical tension, the perception of tinnitus level drops markedly. It takes time and it takes support to do this. But because we know that the neural system, the brain, is a plastic one, the nerve pathways are not set in cement, the ones that make you very aware of tinnitus all the time. They can be modified, but it takes time. A side comment, we found, as Ross Coles reported back in the early 90s, that progress in therapy is always retarded by the presence of unresolved medico-legal issues such as Veterans Affairs claims, workers' compensation claims, accident claims, and so on. And I must point out this is emphatically almost never a case of deliberate deception or criminal intent on the part of the individual. This is not motivated by greed. Rather, it is an inherent byproduct of the victim's situation, the enormous sense of hurt and loss in these cases. So it's an overwhelming human response to their own suffering and the perceived source of it. So if you've been the victim of a crime, naturally you've got enormous built-up resentment. That will help, it's not the right word, it will cause the tinnitus to perseverate as a distressing problem. The disease or disorder cannot be let go of, that is improved, while there is this impending legal action in the background. For the case of veterans with deep-seated sense of being wronged by the system, it's feasible that the symptoms would be sustained indefinitely and hence would be difficult to help these people with therapy. Coles argues that you really can't begin therapy until you sort the legal side out. We've been using a questionnaire. I'll give you a final rundown now on a few interesting results that perhaps help validate some of the assertions that I've made along the way this morning. We use a questionnaire called the Hallam Questionnaire. Hallam has done an awful lot of work on designing questionnaires that are validated, that is, they're accurate, they really measure things like the level of distress, because we can't adequately measure tinnitus by saying your tinnitus is X decibel. We tried to do that and it didn't really lead anywhere. We came upon a questionnaire, this Hallam questionnaire, in about 1995. My colleague Rudy Christen picked it up in a German journal. It had been adapted by a pair of researchers, Goebel and Hiller, in 1992. Their clinic kindly sent us all the English version of the test itself and the transparency used to score it. It's a very simple questionnaire. It's one of these ones where you have to say my tinnitus is always intrusive, sometimes or never, that type of thing. Many questions, internal reliability checks and so on. What we've found is it's an extremely accurate measure of on incoming patients' level of severity. If somebody's got a really bad problem, and you know this well because they just look so unhappy, they're bound to score a high score up the top end of the scale. Anyone will score something on it because some of the items are on things like level of hearing loss or sleep disturbance and so on. But if somebody's score is, say, in about the 30 to 50 range, you call it a moderate scale. 50 to 70 odd severe, very severe, you're up near the maximum. Has an upward limit, it's a raw score. So we've been using this as our sort of measurement tool for about 7 or 8 years. And I recently did a small pilot study on this very topic that we've been talking about today, comparing results for veterans of Second War in Vietnam and then one civilian group. Very small groups. They're all people that were essentially randomly selected from our treatment completed drawer, as it were. Approximately matched for age, and they were all males to eliminate that variable. And interesting things emerge. So we've got 3 groups. The hypothesis that we would put forward is that the Vietnam veterans group, they're possibly going to be worse to start with and not get as much benefit from the therapy. What we did find, we found that 7 out of 7, all 7 Second War veterans improved significantly. 8 of the 10 civilians improved markedly, and there was not a great deal of difference between the civilian results and the Second War veterans, except in one aspect. All the Second War boys were pretty deaf. 3 of the 7 Vietnam veterans did improve significantly. 3 of the 7 improved negligibly. And there was a tendency for them not to attend sessions, have problems with complying with using devices and so on. There's a detailed slide here. See if I can work this little pointer. Looking upside down. Yes, well, they're obviously older fellows. These guys, we saw them in the period 1998 to 2000. Some of them would be over 80 now, I guess. Vietnam veterans, early 50s, civilians around 60. Hearing loss, average 4 frequency average hearing loss we use, 0.5, 1, 2 and 4, because a lot of people have hearing loss only around 4. Civilians, minor hearing losses. Second War veteran, a greater hearing loss, not severe though. Vietnam veterans, 24 decibel. The first score, TQ1, refers to tinnitus questionnaire result first time round at the entry to therapy. Score of 58, dropping for Vietnam veterans to 36, which puts them still as having a moderate degree of a problem. So that's the average, and some of them are obviously still had a serious problem. The civilians came in with a lower first score, TQ1 of 45, and they came out with a score at 18. Now, interestingly, there was some correlation between the number of sessions. The Second War men stuck it out for 6, as almost the civilian figure as well. The Vietnam veterans, less perhaps willing. I'm reading maybe a bit into that. All the veterans used devices of one kind or another, except for one veteran who had absolutely normal hearing, one Vietnam veteran. Some of the civilians didn't use devices, but I won't labour that aspect of the problem. In sum, I believe that the development of tinnitus distress in most people, but not least in war veterans, I think that is the classic example of this neurophysiological model where we're talking about what else makes the problem maintain itself, not just what's going on, the random nerve impulses coming from the inner ear. And it has to involve something more than just what's going on. It's what's making us still listen to the problem. And there are an awful lot of things you can do to stop yourself listening to the problem. And the interesting thing is, when you stop listening to the problem, the signal actually gets lower. And some of the people later today will talk a bit about this. So it's not set in cement. It's a problem that is actually a little bit under our control. There should have been something in there. Oh, it's jumped. Looks like I've gone, oh, what a pity. There was a nice little tinkle bell with that one too, but I think I better stop. Thank you. Thank you.
Just a couple of questions. See if there's a couple of questions for Tony before we move on to the next speaker. So would anybody like to ask any questions?
I think that the general content of the question was, you know, should we be taking into account foods and other substances and so on, and their role in tinnitus onset and distress. And from my viewpoint, I think far too much is made of it. I could be harsher in what I would say. To some extent, I think foodstuffs are almost irrelevant. Obviously, there are substances that can cause all sorts of side effects in the system, but I think we're looking for the solutions to the problem in the wrong area there. I think what I would endorse people doing is lead a healthy lifestyle, a reasonable one. Enjoy a coffee if you like it, enjoy a glass of red wine, but not the full bottle. Not too much fat, all the things that I don't always live up to myself, but I honestly don't believe. The problem is, you see, the body is such an adaptable one that you're looking for some very specific thing in your system. Now, maybe there are people where tinnitus has been aggravated by certain substances, but I think that's not the way to go.
One more question, if there's...
Thanks very much.
Yes.
Thank you. It's not a question,
Oh,
it's just a comment I'd like to make about Mr. Crittenden and his staff over there at Concord. I'm from the Parramatta Self-Help Group, and on behalf of the people that I know that have been to Concord and have had the services of Mr. Crittenden and his staff there, including some vets, I'd just like to thank you on their behalf, Tony, not only on helping them to come to terms with their tinnitus, but also to have a much better in their general health and their lifestyle after being involved in the retraining therapy. And thank you very much.
Thanks very much. Thank you. Very kind. Thanks.
I think that's a good note to move on. And I'd like to introduce Dr. Neil Bustred, who's up at Hornsby. He's very proud of the fact that South Africa never lost to the Wallabies. But he's now with us, so he has to support Australia as well. Yep. Thanks for coming.
I'd like to thank the Australian Tinnitus Association for inviting me to return to talk to you. This is a talk that I gave at a smaller meeting in April of this year, and was asked to represent some of these thoughts. Now, this is really an overview of tinnitus, and I am sure that as I understand it, or as how current research would have us understand it, And a lot of this you'll go through in more detail today. And if I am repeating what's been said earlier, then I apologize, and please feel free to doze off. I'd like to just discuss definitions briefly as we understand them. Tinnitus has previously been largely broken down into objective and subjective tinnitus, but really objective tinnitus is not what we're here today to talk about. Objective tinnitus is sounds for which we can detect origins, and these are sounds like the pulsations that we hear from time to time, clicking, crackling. All these sort of stimuli we call somatosounds. In other words, sounds that come from somewhere in the body, and on a good day with a sharp ear, someone else might be able to hear the sounds that you're describing. Subjective tinnitus comes by a different definition, which I'll come to in a second. I'm not going to talk about hyperacusis and phonophobia. These are different auditory stimuli. Hyperacusis being a sensitivity to sound, and phonophobia by definition a fear of sound. So the best all-encompassing definition for subjective tinnitus, which I can find, is a perception of sound which results exclusively from activity within the nervous system, without any corresponding mechanical vibratory activity within the cochlea. I'm very pleased to be able to say that most of my otology was taught to me by Professor Gibson, and we'll rerun through some of this hearing physiology for those of you who haven't heard it recently. Fundamentally, the middle ear and the cochlea transduced sound, which is a pressure wave, into electrical energy. This activity involves the active involvement of the inner and outer hair cells, and it's their degeneration that we think perhaps important in part of the pathophysiology of tinnitus. The electrical impulse that is created in response to the pressure wave of sound travels up the auditory nerve, from there to the brainstem, a relay station, and from there to the cortex, or the higher center of the brain, where we perceive it as sound. There's one other connection that I think we need to make here when we're talking about subjective tinnitus, and that is the limbic system. In other words, that is the system that translates how we feel about what we hear. Now, all of us have songs, for example, or sounds that we hear from time to time that we absolutely love. And we also have songs that we absolutely can't stand. And our friends love them. And that, for me, in many ways, is the essence, or a part of the essence of tinnitus. It's the way in which we feel about the sound. Now, no one's going to say, God, I love that buzzing in my ear. It reminds me that I'm alive. Or no one's going to say, that little bit of tinnitus is a great melody. But I think sometimes we get into situations where we can't stand the tinnitus. And frequently, that's an association. I've got tinnitus because my teenage neighbor has got a drum kit. Okay, that's not right. I mean, the two may have come on from time to time, simultaneously. But the tinnitus is not because of the drum kit. It's the association between the two that's created the negative response. By the same token, we see patients regularly who come in and say, ever since my ear was syringed, I've got tinnitus. And if you talk to them about the ear syringing phenomenon, it was a terrible experience for them. Okay? And that's another negative association where the two are related in temporal onset, but I don't think are related in pathophysiology. Let's talk about the epidemiology of tinnitus, in other words, the way in which it affects the population. 10 to 20% of the entire population will have tinnitus. It's an enormous figure, isn't it? Not surprising we can fill the auditorium. 30% of patients who are over 65 will suffer from tinnitus. 5% will seek our advice. In other words, this is the group of patients that we call clinically significant. They will seek medical or paramedical advice. And 1% of the population will suffer from debilitating tinnitus that really bothers them. The other thing that interests me is if you place any 94% of the population in an anechoic chamber, so 9 out of 10 or 9.5 out of 10 people if you put them in a completely soundproof environment for longer than 10 minutes, they'll experience tinnitus. Let's look at the distressed group, the patients who are fundamentally concerned about their tinnitus. The other interesting thing about them is that their distress is not related to the psychoacoustic characteristics of the tinnitus. In other words, that means some people will say, I have a roaring, low-frequency, intermittent tinnitus which is driving me crazy. And other people will say, I have a very soft, very high-frequency, continuous tinnitus which is driving me crazy. So the distress is not related to the psychoacoustic properties of the tinnitus. The other thing that's very interesting is that if you transect the auditory nerve, so if you cut the nerve of hearing, then you will not alleviate the tinnitus in by far the majority of patients. So if you actually cut the auditory nerve, you're not going to make them better. The conclusions of these facts really is that the auditory system is probably of less significance than the other parts of the brain in the generation of distressing tinnitus. Now, when I started working with Professor Gibson, he used to mention Professor Yastrobov's name, and his studies were only really beginning at that stage, and he and his wife, I think, have dedicated most of their life to creating an animal model for tinnitus, and I would always be fascinated to have a dinner with them and listen to the conversation between the two of them. Because what they've done is they've fed a variety of different rodents, salicylates, quinine, and exposed them to noise. And before they've done that, they've created a Pavlovian sort of response if they hear a noise. So they get guinea pigs, for example, say approach a water tap. They present a high-frequency noise and they let the water run, and then the guinea pigs would go and learn to go and drink from the tap. Okay? When they turn the high-frequency sound off, they turn off the water tap and the guinea pigs learn that there's no water there. Then what they do is they feed them massive doses of salicylates, 350 milligrams per kilogram, far more than you and I could consume in a day. Okay? And then release them back into the same environment, and they assume those guinea pigs that go and drink from the water tap are hearing a sound and therefore have tinnitus. It's an amazing contribution they've made to this work. And they've done that with salicylates, quinine, and noise. And they've established some neurophysiological models for tinnitus by studying these animals and by studying their brain activity. And their conclusions are, at this stage, it would appear that the presence of tinnitus is created by a loss of electrical activity in the cochlea or in the auditory nerve. So there's decreased electrical activity in the auditory nerve. There is then increased activity in the brainstem. And this increased electrical activity is perceived by the cortex as sound. And the way I like to think of this is if it was a series of relay stations. So if the people in Turramurra don't get the 10:15 train from Hornsby, there's a lot of anxiety on the station, the brainstem, if we think about Hornsby as the auditory nerve for the moment. And some of the anxiety that builds up with the people in Turramurra will be relayed down the line, okay, to the station in Carotta where that is perceived as sound. And then it depends on the response of the station master there. He's either going to say, look, I'm relaxed about the fact the train didn't come in because I know what's happening, or he's going to say, this is potentially a disaster. We better find out what's going on. Okay? So the loss of electrical activity in the auditory nerve translates into increased electrical activity in the brainstem, as if the brainstem was looking for sound. It's not getting sound, so it's making itself more sensitive. And that electrical activity is perceived by the cortex as sound. But that's not all. The next step then becomes absolutely crucial. It's what we do with that sound. How does our limbic system interpret the sound? The limbic system is the conductor of the orchestra of our emotions. It's how we feel about everything. It's a bit sad, but if you think about it, our entire feelings actually boil down to chemical reactions, much as we'd like to think differently. There are two major players. The one is the sympathetic, which prepares us for fight and flight, to kill or to be killed, and the other one is the parasympathetic, which allows us to stay and play. The sympathetic is what is its activity is increased in people with debilitating tinnitus. We feel stressed. You have an adrenaline surge. It's difficult to sleep. You feel agitated and anxious. It is the excessive activity in the sympathetic system in response to the sound which gives the symptoms that present as debilitating tinnitus. This ultimately becomes a conditioned reflex. It becomes very difficult for us to turn it off if it goes for long enough. It becomes Pavlovian almost in its response, or we become Pavlovian. And as I said, this is what creates the symptoms. Before we discuss treatment strategies, I just want to run through quickly some points that we talk about regularly as doctors when we're evaluating treatments. There are anecdotes. The world is full of anecdotes. They have no scientific value. My cousin went to see a guru who had some Chinese chant and the tinnitus has disappeared. That's an anecdote, okay? Perhaps directing treatment, but doesn't really help us very much. Then we have non-randomized trials where we just select a group of people as they come in the door, and some of them we look at them retrospectively and some of them we look at prospectively. So we say, okay, we gave these people treatment, a retrospective trial, let's see how they did. Or we say, we're going to give you 2 different treatments and we'll see how you go. Okay, that's prospective. And then we have randomized controls. We called what's called single blind and double blind. A double blind study is neither you nor the treating doctor know what they're giving you. Okay? And the real definitive test is a double blind crossover study. So I don't know what I'm giving you and you don't know what you're receiving, and I don't know which group of patients you fall into. And then when I've treated you with one thing that I don't know what I'm giving you, I then treat a matched colleague with the same drug or a matched patient with the same drug and then compare my results. So I don't know what I'm giving you. You don't know what you're getting, okay? But someone does, a third party does. We treat one group with one drug, one group with another, and then we cross them over, okay? And we then evaluate the results. Now that's the definitive study that we like to talk about. That's what gives science to, that's what takes the art out of medicine and makes some of it scientific. And the disappointing thing is that at this stage there are no double-blind crossover studies which have demonstrated any efficacy in medication for diminishing tinnitus. That's the sad part. But there's good stuff to come. In essence, our treatment strategies resolve around these points. In my hands, they do. Firstly, to exclude an underlying cause. Okay, that's relatively obvious and relatively straightforward. Then the next step is reassurance. Reassurance from your doctor. And many people come and see me and say, my doctor said, oh, there's nothing I can do about it. Nothing you can do. Go away and live about it. But go and live with it. That's not the case. That's not reassurance. That's dismissal. Reassurance is a completely different approach. The role of support groups, which are fantastic in this. We need to avoid factors which make it worse. So if the next door's teenage drummer is driving you even crazier with your tinnitus, then we need to move house or deal with the drummer. Can we treat the source? At the moment, we can't really. We can't turn off the tinnitus. We can't turn off the brainstem. The brainstem is a pretty important part of our body. It makes us breathe. It encourages our heart to beat, creates stimuli like eating. And without a brainstem, we don't do so good. So we can't treat the source at the moment. We can perhaps modify the stimulus. And one thing we can do with appropriate counseling and treatment is perhaps change the way we feel about the noise. This is a list of some of the drugs that have been offered and tried in the treatment of tinnitus. I'm not saying they're not worth trying. They certainly are worth trying in certain circumstances. Okay? And they certainly work for some people, and they may be part of an overall therapeutic approach. The other form of therapy that we all use is the concept of masking or the concept of sound therapy. And really what this is to decrease the contrast between the tinnitus and the background noise. Okay? Everyone almost invariably who suffers from tinnitus will say it's worse when it's quiet. That's because the difference between what you're hearing from your brainstem and the environmental sound is so great. So masking and or sound therapy, either by using hearing aids or by using tinnitus generators or noise generators, narrows the gap between the background noise and the tinnitus. But one thing that's important is that you shouldn't mask the tinnitus out completely. You should be able to hear it if you concentrate on it. So if you are living in a sound-rich environment and you're playing CDs to yourself at home, you should still be able to hear the tinnitus if you want to. Because if you mask it out completely, when you turn the CD off and you find yourself in silence, the tinnitus will come back with a vengeance. Enhancing the sound environment can be done by a variety of techniques. You're using hearing aids, noise generators, combinations, etc. And overmasking is the concept that I was describing. The other thing that creating a rich sound environment is an integral part of tinnitus retraining therapy. And you've just had an expert talk to you on that. And at this stage, the tinnitus retraining therapy is where we're having the most success with our patients who suffer from debilitating tinnitus. And it treats tinnitus by inducing a habituation. Habituation, for me, the best way of explaining that is when you drive your car, you think about a multitude of stimuli that are coming to your body. There's an enormous amount of information that's coming through. Hopefully you're enjoying the music that's playing. Okay? Or perhaps it's one of your daughter's M&M CDs and you're not so partial to the music. But you think about it, all the information about the clothing that you're wearing is coming at you, whether you're sitting or not, whether you're standing, all that information is coming through to your brain, but what you focused on is really what your eyes and your other senses are peripherally playing at. So you are so habituated to driving the car that you ignore all the other stimuli that are coming and just stay focused on what you're doing. Okay, except of course when someone cuts you off and then you lose all that information. But all the process of habituation applies to tinnitus retraining therapy. You're trying to habituate to the tinnitus to get to a stage where your brain says, I know what that is. That's not really important for what we're doing right now. Let's suppress it. And with time, the stimulus slowly diminishes. And that's the integral part of tinnitus retraining therapy, but it is still not a cure. It doesn't get rid of the condition. The final goal with TRT is to get the tinnitus to stop bothering the patient, not to get rid of the tinnitus. Okay, I won't go through that. We've dealt with that already. The other thing that I always tell the patients is that they may get some initial deterioration. It's a long process. It's possible that you may get rid of the noise generators, and again, it's not a cure. What about other therapies that have been suggested? Acupuncture. I've had a very interesting discussion with an acupuncturist who informed me that one of the things they could do was increase electrical activity in the inner ear. Now, we can't actually demonstrate that, but it's an interesting thought. Again, that's anecdotal. It works for some people, but no, it hasn't been proven to work exclusively for a group. Electrical stimulation would be nice if we could be able to improve the electrical flow along the auditory nerve, and I think electrical stimulation is basically what we do with sound therapy. Biofeedback, and there are a whole host of other therapies that have been offered. Where does the future lie? I think the continued work of Yastreboff and his wife and other very involved neurophysiologists in the animal studies is a wonderful area of promise for us. Advanced imaging techniques, PET scans, if we could perhaps evaluate the physiology of the brain rather than just the way it looks, in fact how it's functioning with our tinnitus sufferers, that may help us in devising appropriate treatment strategies. And I think we need to work together both as doctors and as individuals in support groups and in medical teams. Thank you.
So I'll ask Neil to stay and answer a few questions. We've got a moment. So, any questions from the audience? John Tonkin.
Neil, how do you evaluate the phenomenon? The absolute silence occurs, the property has turned on. But though that property has often been absolutely so you get up in the morning and turn on a property, it's absolutely
John, I think that's an interesting point. I think that's nicely explained by this neurophysiological model, that as soon as you get electrical impulses traveling along the auditory nerve with the cochlear implant, the natural activity in the brainstem slowly diminishes. That enhanced electrical activity diminishes and the tinnitus therefore disappears. I think that does hold promise in as much as if we could increase the natural electrical activity in the auditory nerve, particularly in those frequencies where we've lost cochlear function, then perhaps we may be able to suppress the tinnitus. I think that's an enormous field of promise.
Some people might argue they can do the same thing with their digital hearing aid inside their ear.
Yeah.
So it's the same thing, it's to try and improve the signal.
Sorry, could you ask me that again? If you have tinnitus, will it steadily, progressively deteriorate? Yeah, if your hearing continues to deteriorate and you do nothing about the tinnitus, then yes, it will get worse. You need to, if it's bothering you, you need to get advice and seek treatment, and you need to avoid exacerbating factors. And if you're continually assaulting your ears with the noise of a jackhammer, you need to do something about that.
But hang on, no, I think you meant if you go into silence, will the tinnitus get worse? Silence is not golden for tinnitus, it's the opposite. If you go into a silent situation, your tinnitus will get worse. Yes, there's no question.
Oh, yes. Yes. The bad headache generates the adrenaline. That's part of your limbic system, part of your sympathetic system. So all those stimuli, a bad headache, an argument, even people talk about stress. Stress fundamentally is an adrenaline surge, even good stress, when it's 14-all in the Wallaby South African game, and my case of beer starts to disappear, the tinnitus goes through the roof.
So the gentleman at the back, yeah.
The increase in electrical activity in the brainstem is thought to be a local response to the absence of electrical activity in the auditory nerve. As if the brainstem was heightening its senses, was trying harder to look for the sound. I mean, a lot of this work is paralleled with people with a phantom limb syndrome. So if you cut off a hand, if you remove a hand, people still get pain from that hand. And one of the ways in which they've treated that is they get the good hand to go into a series of prisms, so that if you look through the prisms, it looks as though you're looking at the hand that you've lost, okay? And then as you manipulate those fingers, some of the phantom limb syndrome disappears. Well, that's the question. We can't do that at the moment, no. Can't do that at the moment. But that's perhaps an area of research that is very exciting. I haven't noticed it, and I always treat those with circumspection, because, if there's nothing worse than to suggest to a tinnitus sufferer, if I give you this medication, it'll go away. I think that's completely misplaced faith. And part of those therapies are part of the whole counseling, sound-rich environment, tinnitus retraining therapy. They all work together. And if you say to a patient, if you take this, you'll get better, and they don't, they're going to be extremely unhappy. So none of those have had randomized prospective trials, double-blind crossover trials that I'm aware of. Can't trust those South Africans. It's a similar parallel to what we all talk about. It's a similar concept to sound therapy, enriching your sound environment. They perhaps have tried different techniques of it, but it's fundamentally the concept is the same. Yeah. I'm not sure. I don't really know enough about it to comment on it.
Oh, yes, sorry. Or we'll repeat the question. Well, is there any more questions from the audience, or should we move on? So thank you very much, Neil. Thanks. The next speaker is Dr. John Carotta, who works out at Westmead and at the Children's Hospital. He used to work at the Children's Hospital anyway, but he's out Westmead way, and he's had a special interest in tinnitus, so I'm pleased to say he's arrived. And thank you, John.
Good morning, ladies and gentlemen. Morning. Thank you, Bill Gibson, for the introduction. Yes, I still work at the Children's Hospital as well as at Westmead Hospital Adult Section. I was pleased to catch up with the last few questions that Neil Bustred was asked, because I feel for the first time at one of these gatherings there's some like-minded speaking insofar as other ear, nose and throat surgeons are seeing and looking at tinnitus as being more to do with the brain and less to do with the ear. Certainly in the acute situation, the ear has been paramount, but you people sitting here, I'm sure, have had it for more than a few days. You've had it for years, and by this time it's somewhere up in your brain. And I was pleased to hear Neil emphasising that side of things. And in fact, he's stolen a little bit of my thunder insofar as that's where I wanted to concentrate our approach today. I wanted to talk about drugs and tinnitus in a fairly general sort of way, because it seems to me every month or two there's another medication or herbal therapy or treatment suggested. And we always say in medicine and surgery, whenever there are a dozen things which can be done, or a dozen operations which can be done for a particular condition, we know that not one of them is probably tremendously good. Everybody is still looking. You've all seen that diagram of the ear. But as I said, most signals do start in the ear, and they're started either by outside noise or by some damage to the inner ear itself. It starts sending a message up to the brain when there wasn't one from the outside, and that's what we all understand by tinnitus. The cochlea, and that's a cross-section of that spiral of the snail, and down in the middle there are the little hair cells. Is there a laser pointer there? Okay. When the V's at the bottom are the outer hair cells, and the single row at the top are the inner hair cells. On the left-hand side, your left, is a healthy inner ear, and the V's on the outside are like little shock absorbers. But they're shock absorbers which in fancy cars can be adjusted to be sharper or softer, so you have a smooth ride or a tight sports car-like ride. And it's the inner hair cells which, when they bend, they send the signal to the brain. Now, with some ototoxic drugs like streptomycin, you can see what it does to those hairs. It looks like they've all had zero weed killer on them. They're starting to wilt. finally, if there's too much, they wilt completely and die. But the nerves haven't been killed. They're still firing. A way I like to look at it is if I was up here with an old-fashioned microphone or an MC, he'd be wandering across the stage, talking to you, and if that microphone had not had the wires screwed in properly, every so often his voice would cut out and you'd hear a and then the voice would come in again. Your inner ear, in a way, is that microphone and its cable starting to disconnect, and you start getting static from the little bad connections. So the sound goes from the outside, but the clicking and cracking from the cable starts coming through, and that's what most people initially notice as tinnitus. Now, once that signal gets up to the brain box, it has to go from one nerve to the next nerve to the next nerve, and every time it relays, it can be kicked up, be accelerated or slowed down. And this is what Neil Bustred was talking about, what's happening with that limbic system and with these other chemicals like adrenaline. They act up there in the brain. So we can simply say that by speeding up the signal, the tinnitus is increased, and by slowing it down, the tinnitus is decreased. So if you've got a good little battery and an amplifier up there, you can kick it along each step of the way. You don't really want to. So stimulants will give it a kick along, and the stimulants we all know are things like caffeine and adrenaline, and they come in at one section, and other things will slow down the signal. When you relax, when you soothe down, or sedatives. And we all keep seeing that word Xanax. It seems to be through everywhere. And Xanax is a very strong sedative. It's like a super Valium. Now, when anything is coming up over time into the brain will adjust to it. It wants to concentrate on what's happening at the time, what is new. Now, as you're sitting there, you're comfortable, you've got your legs folded, you're bent in a certain position, you're looking up towards here, but you know there are things happening. There's a Garvan Institute sign over there, there's another one up here. They're all things in your peripheral vision, but your eyes are focused. Unless you've got macular degeneration, your eyes are focused up here and you see well. Provided those signs and the lights on the side stay stable, they won't bother you. They're there, you know they're there, but they're not bothering. But if they're flickering on and off the whole time, you'll say, for heaven's sake, will you get that light on or off? It's sending me mad. And it's the same with the tinnitus. If that signal stays stable, your brain is designed to adapt for that and get on with life. But if you keep changing it, or if it keeps changing on you, you'll be kept alerting to it. You'll keep noticing it. So the things which move the signal up and down are the ones which exacerbate the tinnitus. Things like the adrenalines and the caffeines and the like. So the brain the whole time is trying to ignore it. We just have got to help it without hindering it. So that the drugs we now know seem to have the best effect on the tinnitus are those which have the greatest effect on the brain. The Xanaxes, the Valiums, prothiodyne, caffeine, your Prozacs, your Zolofts, they're all very good because they are basically brain-acting substances, not ear-acting substances. Now, some we've been lucky and found that they have affected the brain, but we didn't expect them to. Things like Ginkgo and aspirin. Now, we know that aspirin affects the inner ear. It can damage those hair cells, but we find it also affects some of the relay stations too, an independent effect. So the aspirin has a double whammy. But again, a small dose of aspirin, which a lot of us take, helps the circulation, gets more energy, more sugar, more nutrients up to those little cells in the brain and helps them work better. So the small dose of aspirin is fine, but like many things, a big dose can be too much of a good thing. What we're hearing again about is lignocaine, lidocaine in America. John Shea has said if you give it for a few days or a few doses, it magically settles your tinnitus. John Tonkin is sitting down here today. When I was working with John Tonkin in, I think, 1978, he had me giving that therapy then. It is certainly not new. And it works well for some people for about a half an hour. And all of us are here not because we've had tinnitus for half an hour, because we've had it for half a dozen years. And I think lidocaine also probably works, like many other things, by hoping that it works as time goes on. But lidocaine is a local anaesthetic. We're using it all the time. Injections, for operations. I use it day in, day out. Now, local anaesthetics work by settling down electrical activity. So we try to think, well, what other drugs settle down electrical activity which can be taken by mouth, because lidocaine can't be. It's broken up in the stomach. So, what's a condition where there's shooting off of electrical activity and we need to take a tablet to control it? One of it is epilepsy. So let's try the anti-epileptic drugs. And Tegritol, Carbamazepine, is one of these. I've used Tegritol a number of times, but nobody has stayed on it for more than 3 days. The disease is worse than the condition. The treatment is worse than the disease. They become quite dizzy, and it can have longer-term effects on your blood count. So unless you've got a life-threatening condition like epilepsy and you can't take anything else, you're better off avoiding it. Just to remind us that the signals come from the cochlea at the bottom, go to the brain stem, and we can see a number of circular relay stations which go up to the brain. So the drugs which have the strongest effect on the brain will have the strongest effect on the tinnitus too. Mostly for good, but there's one of them that we've got to be just a little bit aware of, because in the occasional patient, maybe 1 in 100, 1 in 500, the aurorics type, those SSRIs, can give a kick along to the tinnitus. I mention it because a lot of people are anxious about it, but in fact it's a rare occurrence, but it seems to be fairly well documented. A lot of people do have a temporary increase in the tinnitus when they start it, but rapidly over a couple of weeks it settles down. But there's the rare patient where it seems, because a strong brain medication is used, for some reason or other, the chemicals in their brain just keep it going. So we just have to be a bit careful of SSRIs. However, we all hear these anecdotal drugs, responses. So-and-so Mavis tried this, or it's up on the internet, 4 patients had that, and it's been marvellous. Medical science has grown through trying to work out what is actually working and what we just think is working. We're trying to find out what's the placebo, what works because you want it to work, and what works because it does work. If you paint a hospital pale pink, or if you take green pills, the green pills work better, say, than purple pills if you've got anxiety. It can have the same chemical in, but more people will feel better taking green ones than, say, purple ones or blue ones. Our whole culture is based on labelling. What colour? Why did you buy that bottle of wine? Probably 9 times out of 10 it's because you like the label. Why'd you buy that block of chocolates? How many people are going to bring out black and gold for their guests? They're not. They're going to put it in something different. And it's the same with tablets. Also, it's been a medical aphorism for years that it's best to use a new treatment or a medication as soon as it's out, because it always works better, because a few years later people realise it was no better than anything else. But it's the expectation, again, you've got to be in there fast. Nobody really likes to eat black ice cream, but if you had your eyes closed, you probably couldn't tell the difference. It's all in what you see and what you expect. And again, when I have these inquiries about, they heard about some such drug on the internet, you've got to keep thinking how many people tried it, how many people were tested eyes closed and eyes open, how many people were given it by a person who did not know whether it was the real drug or the pretend one. And until we do those sorts of tests, we're really tricking ourselves. And we don't want to do that. We want to find something which is going to help people. Because medications and treatments are taken not just in isolation, but they're taken at certain times in your life with certain expectations, with certain other drugs, things can just be the last little bit that helps, or they can be the straw that breaks the camel's back. And sometimes things get a bad name because they're the straw that breaks the camel's back. Almost anything would do it then. But for the most part, they're actually good drugs, and vice versa. They get a good name, but they really weren't much good anyway. So I've tried to put it around so you understand why one thing can work at one time for one person and not for another. So while a spoonful of sugar helps the medicine go down, you've got to take it with a grain of salt too. Okay? Some of the things we're seeing coming around again or for the first time. Vitamin B12 seems to be one which is cropping up at the moment. And it appears to me that came through because it was found that persons with a vitamin B12 deficiency and had hearing problems, the hearing improved to a degree if they were given some vitamin B12. There aren't many people around here with vitamin B12 deficiency unless they've got gastric cancer or gastric part of their stomach removed. And again, it's drawing somewhat of a long bow to say if you have some vitamin B12, which I might add can only be given by injection, it's going to help tinnitus. So we need a lot more evidence before we start running off to the GP wanting to give us vitamin B12 injections. Zinc. Certainly we probably are all running a little low on zinc. Zinc has been used in zinc cream and the like for years. It works well to heal things. It is useful for regenerating tissues. So there won't be anything to be lost by taking a zinc supplement, and possibly something to be gained. Ginkgo we've heard about for years, and possibly it might be something useful, but then again we have still to see a really good study to prove it. But there is increasing amount of anecdotal evidence, and the experiments with needles into the brain show that it actually does affect some of those relay stations. But remember, you've got to be careful. It works similarly to aspirin on the blood. St. John's wort is an antidepressant, but is also highly photosensitive. You can get skin rashes. People who know about cattle and farms know that the white cattle get a lot of troubles with their skin if there's St. John's wort around. Valerian is a mild sedative, just like Xanax, just like Valium. It's very hard with these these herbal medications to know what dose you're getting. But the Valerian is probably fairly weak, and you'd overall be better off with a controlled dose of a medication we know something about. You'd really be better off taking a Normoson of a night time if you're having trouble, or some propiodin. At least we know the dose and we know what it does. Acupuncture has been tested many times. Doesn't work, full stop. Ginseng doesn't work. people have done tests on this tinnitus drug called tinnitus, a herbal medication, did not come through the test at all. Cyclandolate is to open up the blood vessels in the arms and legs. It doesn't help. Hyperbaric oxygen in a decompression chamber doesn't work. Melatonin might work for sleep deprivation or trying to rearrange your biorhythms after you've been flying and your time clock's out, but it doesn't work for tinnitus. Now, we have lots of lists of drugs which seem to make things worse in some people, but with all of these lists, what they are is lists of medications which somebody has written in and said, I took this and my tinnitus got worse. It does not say, I took this and I was also going through a bad patch of something else, or I took this and I was also taking another medication. So again, anecdotal evidence has got to be seen as just a pointer and nothing more. And the thing is, if you're going to go on a trip, if you're going to go on a hike, you just don't sit, and you need to get at a certain point, you need to get home by a certain hour, you just don't drop up to somebody and say which way, and they say, oh, I think it might be over there, and leave it at that. And you don't check it out any further, and 4 hours later you're in the opposite direction from where you wanted to go. You ought to take a few opinions. You ought to get as much evidence. So I'm emphasising that even though it's good that we watch out for new medications, we must always try and analyse them and find out what they're doing. That the noise can start in the ear, but it's what happens to it on the way through which is what is more critical in the longer run. But having said that, if you keep taking medications which keep damaging the ears, you're going to cause more and more ear-type tinnitus as well. I often think of that movie, The Castle, where that family was living under the flight path. They thought it was fantastic, so convenient. Seeing all this technology, it's exciting. Why wouldn't everybody want to live at the end of Mascot Airport runway? They had a positive attitude to something that we see as very damaging. It can be either way. It's what you get used to. It's your approach to things. We want to try and minimise, reduce tinnitus distress. Not one of us is saying you will not hear the sound. What we're all trying to do is to try and get it so that it's livable with, that's down there in the background. You know it happens to be there, but you can get on with life. And if we can do that, if we can all work together and find out more things that do that, the better. Thank you.
We'll have a few specific questions for John. I thought you were going to talk about animals, but anyway, that's fine. Okay. I think everybody was very happy you spoke about what you did. So any questions about medications to go to John?
One thing I wanted to ask in connection with was ginkgo biloba. So I haven't got any medical knowledge or anything like that, but I've had the condition of tinnitus for about 10 years, and I've been taking, with ever decreasing volume, but I've still been taking ginkgo biloba. I think it might be the placebo effect. But the thing is, I agree with you completely on most of the points about the medicines and about possible placebo effects and all that type of thing. But in the case of ginkgo biloba, there was a thing that you shouldn't take it for more than 6 to 8 weeks. And I'd just like to find out a bit more information from you about that. Thanks.
Again, with injunctions, with warnings and cautions from manufacturers and with all sorts of people, just think about the little tabs you've got on the clothes that you buy at Woolworths or the children's T-shirts. Do not put in the dryer. Do not do this. Do not do that. Dry clean only. A lot of these things are done for the protection of the manufacturer as much as the protection of the person. I think it's wise that we warn people not to live on things too long, because nobody really knows. It's probably fine in a modest dose to keep on these things, the ones we know something about. And Ginkgo's been around for a long time, as we know, and no doubt you're using it in a dose that's pretty well recognised as an acceptable level. Therefore, I would say, provided you don't have other medications to interfere and interact with it, like I mentioned, you know, your aspirins or your non-steroidal, your arthritis medications, it'd probably be fine with that one.
Dr. Carotta, you had an earlier slide with streptomycin.
Yes.
How quickly would you get that effect on the
Now, streptomycin, it will A, depend on the dose, B, will depend on how long you use it, and D, will depend on how quickly your body can get rid of the streptomycin too, how good your kidneys are. And furthermore, if we give a dose of streptomycin, it seems to be some weeks, quite possibly, before the effect, the total effect, is noticed. A single dose is probably fine. It goes high, then drifts out. But if we give a big dose and give it again a day or two or three, if we give it, say, 3 or 4 consecutive days and we don't check the blood level, you may have too high for too long. If you're having streptomycin or similar sorts of aminoglycoside antibiotics, you'd be in hospital and you'd have your blood levels of streptomycin taken just before you have each dose and a little while after to see how high it goes. You have what's called peak and trough levels, and you have your kidney function tested before you even start. So we're very much aware of the damage that streptomycin type medications can do. A person will not go more than 24 hours in a hospital without the level taken, and it's repeated for the first few days every day, and after that every 2 or 3 days.
Can I ask the question, is tinnitus a new disease of the 21st century because of the noise we have, which we didn't have a century ago? Is it a contributing factor?
Well, there are two things there. Yes, there is more noise, and B, we are getting older, and C, we're talking about things more. It's a bit like child abuse. Is that a disease of the late 1900s? We see a lot of the cases are ones which occurred 30 and 40 and 50 years ago. So no, it certainly is a disease more of the industrial era, but the original tinnitus was bell ringers tinnitus. Okay, the Hunchback of Notre Dame had it.
Is anything being done to the schools to let the children and the young adults know the damage they do when they expose themselves to noise?
We've just had Hearing Awareness Week here in New South Wales, and there was certainly a lot of publicity then. I don't think it's got to the point of no hat, no play, or no tinnitus, no play loudly, but people are more aware of it. The difficulty is even in the workplace. Young people, as we all know, are invincible. They're invulnerable. We only have to see the way they drive, the way they drink, the way they live, the way they take drugs. If you can get them to turn the music down, you're doing very well.
The Australian Tinnitus Association has produced a kit for schools, which has been very well received, which is taken around all the schools to warn them about the risks of overexposure to noise. But I agree with John, because I was going down Balmain, Darling Street, and a car went past with the windows down, and I think there was like 220 decibels coming from this side. Yeah.
What about the workplace? Some of the factories and some of these places that also have noise.
Well, that's a constant area of activity since about 1980. There's been one of the greatest sources of workers' compensation payments are for noise-induced hearing loss. It's very much most employers, certainly the bigger companies, are very much aware of it, but there are still backyard people who try to run away and to or bury their heads in the sand and not know about it. But yes, they're very much aware of it.
I would just like to say that I have a B12 deficiency for many years, and I have regularly had the injections, and I found that it helps the tinnitus, the nausea as well. So I found it very satisfactory.
Thank you very much. That vitamin B12 deficiency is associated with peripheral neuropathy and damage to the brain. So it is really not surprising that if you do have a B12 deficiency, things like tinnitus will be improved. Yes. Okay, the question has to do with my mentioning that anti-convulsant therapies have been tried because their action is somewhat similar to local anaesthetics. And the question specifically asked whether patients who have been given Tegritol noticed a change in their hearing in particular. Is that right? And their understanding. I don't think we've got the answer on that. As I said, in my experience, about 1 or 2 weeks has been the maximum anybody has been able to tolerate the medication, and I've not read anything where those sorts of questions have been properly addressed.
No,
Just
before we
one
go
quick
on,
one. It's not actually a question.
is it specifically for John? Because what I'd like to do is bring all the speakers this morning up on the stage, and then we'll direct the questions to all of them.
It's really not. It's just a comment back from somebody who made a mention at the back about programs for school children. Having used Jen Burnley's program put out by the ATA and the Australian Hearing video with a group of children from Kindy to Year 12, I actually copped quite a lot of flack from parents ringing saying, what are you telling my kids? Because now we can't even have the radio on in the house because you'll make us go deaf.
Okay. So can I, John Tonkin, Tony Crittenden, Neil if he's here. Is Neil? Neil's here? Okay. Take a seat. I thought we could put them all on the spot and see if they actually have the same opinion, okay? So we'll just wait for them to sit down. So this can be any question you like. It doesn't have to be specifically on medications or anything like that. We'll start. Right, this lady over here.
I've got one here, Governor.
We'll repeat the question if there's a problem. Can I repeat the question? If people have an allergy to streptomycin, would it have any effect on gentamicin treatment? Are they related?
There are people who do have a specific biochemical reaction to gentamicin in which they have, as a result of that, very much more damage to the inner ear if they have to have gentamicin. As I understand it, that sensitivity is rare, but it certainly occurs. Do you agree with that, Bill?
Yeah, I don't know the answer to that
Neither
question
do I.
either.
I
Ask John Carotta.
I don't know that there's a test. You know a test, John?
So the allergy that you're referring to is some sort of skin reaction, or is it a particular sensitivity to the effects of the drug? When you use the word allergy, could you just clarify that? No, they're similar treatments. They belong to that group I alluded to called aminoglycosides. And streptomycin, kanamycin, gentamicin, they all act similarly. To a greater or lesser extent, they act at the same place. So what is damaged by one, if you give a similar medication, it will just add to the damage.
Good. And this lady here in front. If I may, I'll direct to this lady first, if I may, and then she's been very patient, yes? Can you?
Yes, I have a question for Professor Gibson. Professor, could you explain what hyperacusis is, and is there any treatment for that? I feel I do have that problem, and I'm anxious to know if there's any way out of it. So it's a shocking thing to have, I can tell you.
Hyperacusis and tinnitus go very closely together. I'll ask the panel as well, but basically this limbic system that's been alluded to by Tony Crittenden and by Neil and by John is an amplifier in the brainstem, and it amplifies your awareness to sound. And when that thing goes into overdrive, then a whole lot of sounds become unpleasant. And for these people, silence is the wrong way to go. The more you try to block off the sound or to prevent hearing the sound, the worse it gets because you drive the amplifier. And what they have to do, and Tony, I'll ask Tony to describe it, is you have to reintroduce sound into these people's lives to get rid of the hyperacusis. So, Tony.
Yes, there is a strong connection and association between hyperacusis and tinnitus distress. And we use, or try and help people use a similar approach. As Bill says, it is fatal if you get the person to avoid noise altogether, because then they become, well, it's almost a phobic thing then. What we try and encourage people to do is to, if their hearing is normal but they're concerned about going to public places with noise, some sort of filtered earplug which actually lets them initially cope with busy shopping centres and whatever, but not block them off entirely, and then not to use that sort of thing for prolonged periods of time. The other thing that sometimes helps hyperacusic people is the use of white noise devices, where again you introduce low levels of signal. As Neil Bustred said, you don't mask the tinnitus. In this case, you don't present the signal at a very prominent level. It's in the background, and then the idea is to turn the volume.
I apologise to that gentleman. I didn't know you were holding the microphone. I didn't mean to confuse issues. Now I'll ask the lady to give her question.
Thank you. I'm referring to the section on the animals, experiments on animals for the sake of finding a cure for tinnitus. Of course, we all know that animals do not talk. So if we administer a certain treatment to the animals, how do we know that they can't say, I'm feeling better, or this is making me worse? So how is it going to benefit us?
Does anybody want to answer? I have a... I know how they do it, but I'm not sympathetic. I too don't really like animal experiments particularly, but what they've done is they've made the animals respond in a certain way to noise, so that, as Neil said, when they hear a high-pitched sound, they go and have a drink, and they get used to that. Then they give them the aspirin, high-dose aspirin, and the animal hears the high-pitched sound, doesn't realize it's not coming from outside, and goes away and has a drink. And then people deduce that the animal has heard a noise, but in fact there's no noise there and is therefore suffering from tinnitus. And that's how they do it. I'm not condoning it, I'm just telling you how they do it. Anybody want to mention about animals?
I was also going to say that if you put electrodes into the brain, you get a similar signal from the effect of the drug as you do from the effect of noise, if you put it in the particular spot. So again, they're corroborating pieces of evidence that what's happening in the animal is probably similar to what's happening to us.
I'd just like to put a tiny word of caution about that work of the Gastropov, husband and wife. It's a little bit at variance with the work being carried on at Montpellier by Professor René Pujol. In his work, he showed, using rats as the experimental animal, that the animals exposed to noise have an increased neurotransmitter secretion from the base of the inner hair cells. And this is, in other words, it is not a cessation of activity, but an increased activity from the inner hair cells. And he's shown that very nicely. And he showed the reduction of the neurosensitivity activity in response to certain treatments. And so there does appear to be a discrepancy between the work of Jastropoff and the French work, and the discrepancy is not resolved yet.
No, but there may be more than one cause of tinnitus, of course. So there may be peripheral tinnitus that Purgell described, and then there could be more central ones. But the problem is that anybody who's had tinnitus for more than about a week, the central effects begin to be the predominant ones. That's the problem.
Well, that was beautifully cleared up by another Frenchman. They showed that if you have had the bad luck to have, for example, a terrible result from a stapedectomy resulting in loud tinnitus, if you had the cochlear nerve divided within a week, the tinnitus stopped. But if the operation was delayed for more than a week or 10 days, it made no difference. So that really...
That would never happen to us patients.
No,
though,
I've
John,
never
would
seen
it?
that.
And another question. This gentleman here.
Yes, my question's to Tony Crittenden. It appeared that you suggested that what war veterans experienced, civilians could also have that same position in the workforce. It's been my experience with contact with my local GP, ear, nose and throat specialist, and especially with the insurance doctors, that in their opinion, although tinnitus could be caused through stress or exposure to loud noises, it's really just because you're old age, and they tell me to go away and put up with it and get used to it.
Yes, it's a difficult one to unravel, probably impossible, but the example of the veteran, I guess, is to use something which is so manifestly stressful, and therefore the evidence is the incidence of tinnitus distress is so high in this group. In the normal community, in normal life, obviously there are any number of terrible things that can happen to people, possibly not with the sort of ongoing thing of being, say, in a combat area for 6 to 12 months or whatever. But I mean, certainly people, you don't have to have hearing loss to have tinnitus. Well, let me put it this way, you don't have to have measurable hearing loss to be distressed by tinnitus. And it's plausible that people, but harder to prove in a legal setting, that it's perhaps attributable. I know one case, a patient who saw me, he suffered some form of noise insult down at Port Kembla, and it was to do with some huge vehicle that had put out some unexpected noise, and he was right on top of it, and there was all sorts of disputes about what caused what. But the guy had certainly suffered some sort of a conversion. This isn't the right word, but I'd call it a conversion. So he'd gone into some sort of stress panic reaction after this event. And one of the things that exacerbated it was that it was handled very poorly on the site by the health people there. And the guy had an understandable resentment about the thing. I mean, I'm getting a bit away from it, but there are complexities in this issue. And what I'm trying to allude to the fact is that you'll have damage to the ear often enough that's one necessary condition. But having damage to the ear, as the philosophers say, it's not sufficient to cause a person to then go on to have great distress from tinnitus. Other things kick in. And this, a lot of talk about the limbic system, well, that's what I'm referring to in action when I talk about the emotional distress that the veterans and others experience.
Thanks.
Thank you.
Another question. Yes, Connie?
I was told that I've got profound deafness in one ear, and Meniere's, and tinnitus, and what is it,
Hyperacusis.
Acusis as well. Now I was told that that I had no chance of wearing a hearing aid because I had profound deafness. Now, if you can't block out, if you can't join in with the sound, with the noise in that side of your head, how can you block out the tinnitus so much? I mean, I do by trying to forget about it. I can sleep well. I don't have problems going to sleep overnight. I just block it out when I'm busy, whatever. There are times when I can do that. But like now, for instance, it's really loud.
Well, that's understandable because
and I think with everybody in here, it would be because of this, the surroundings.
Yeah.
You know, socially, it's quite debilitating, and with my job, it's quite debilitating. But the question I'm asking is, I was told I can't wear a hearing aid. I've had problems with a couple of ENTs that I've been to. They try to say to me that, well, forget about it, go away, we can't do anything about tinnitus, we don't know anything about it, basically.
I'll have a shot at that one. I think it is, you have got a challenging problem because people who tell you that you can't wear a hearing aid in the dead ear, that's true. I mean, you're not going to get any sound signal in through that ear. If you do, it will in fact be by turning the device up so loud that you're actually hearing the thing through bone conduction in the good ear. But you've got the good ear, and I hope it is a good ear to work with. So I mean, obviously you're getting some sort of sound input, and you can use sound sources to distract yourself. One of the problems for folks like yourself is if we try you with say your hearing's too good to have a hearing aid in the good ear, which we'll assume must be the case, using a white noise device is a little bit complicated. It's not impossible to try, it's just that then we're inevitably slightly compromising, no matter how open the fitting of the device. We're slightly interfering with your hearing function. So I guess I'd be thinking of somebody like yourself. Well, I think probably you're doing pretty well everything you can with a difficult problem, but realise that when you're hearing other sound through that good ear, it is going up to the brain and having some positive effect. Yeah.
Well, I was
John?
Sorry.
There's a man in this room with the same thing as you have. And we fitted him with a cochlear implant. Where's Brian? Brian's here. He was totally deaf in his ear. And he had exactly the same situation as you. But when his cochlear implants turned on, you go and talk to him after this. Would you like to talk to him? He's in the same row down there. You talk to him and find out what we did for him. Right?
I was actually told I couldn't have a cochlear implant, but that's
Who said that?
It's not really not important. It's not no one of significance. I'm telling you.
No one here.
Right, exactly. But also, you know, another thing I wanted to ask too is, I mean, I just woke up with this deafness. First of all, it started with Meniere's, boom, like that, and I was told it was a viral infection that caused this. It was a slight hearing loss, like 12%. And then eventually, 4 years later, I woke up with, you know, 4 years later, I woke up one morning again with profound deafness and tinnitus. So I just woke up with it. "10 years, 20 years. It was a real shock, and emotionally, and I agree with you, I think that a lot of these things are exacerbated by emotional problems as well. You know, if emotionally...
They're exacerbated, yes. Right? But undoubtedly your neural system underwent a massive insult, so the brain has suddenly lost approximately half its input from that side, and all these return mechanisms where the brain's trying to crank out signal that's no longer coming up that would be the absolute extreme case of what we're talking about, I guess. Yeah. Which we're very sympathetic to, but you're obviously doing a lot.
All right. We must let somebody else have a go.
As a
fairly long-term Meniere's disease sufferer, it was music to my ears this morning to hear Dr. Tonkin tell us about this new drug, gentamicin, I'm sorry. Without putting Dr. Bill on the in this focus, could you perhaps let us have a few...
Well, no one's going to say they've got the cure for Meniere's. Actually, what Professor Gibson does and what I do is basically the same. He is abolishing the source of saccharine secretion. In a more guaranteed way than I do, he actually cuts off the source of saccharine secretion. And I believe I've reduced it with the gentamicin. So, but there's a lot to learn. We don't know what controls the secretion of saccharine. It may be another hormone secreted by the anterior lobe of the pituitary. It may be entirely controlled by the blood supply or by the nervous system. The more we think about it, the more interesting it gets. But I do think, though, that the discovery of saccharine is the most fundamental discovery we've made since Meniere's original article.
Meniere's disease is a condition with 3 to 4 components, and it's the vertigo which is mostly affected by these treatments, particularly gentamicin. And it's the vertigo which is really what disturbs most people the most. The hearing, if there's a benefit with the hearing, the fullness and the tinnitus, we consider that a bonus. But if we're managing Meniere's disease, we're trying to stop people getting sudden attacks of incapacitating vertigo. The operations, the local treatments are very good for that, excellent. But when it comes down to the cochlea, the hearing, the fullness, the ringing, they're not nearly so reliably effective.
Gentamicin been used, as you said, for many, many years, but mainly to knock out the balance part of the ear and try to preserve the hearing part of the ear as much as possible. And it's been the frontline treatment really in Scandinavia to do it that way. Then more recently, people tried low-dose gentamicin, which is putting small doses in, first of all through the catheter, people in San Diego. And what hasn't happened yet is it's still anecdotal, unfortunately. We still haven't moved into that proper trial stage that Neil Bustred was talking about, where we need a double-blind study. This actually would be quite an easy substance to do a double-blind study on, because pledgets of gel foam could be supplied to the doctor, and the doctor need not know whether it has the active ingredient or not, and obviously the recipient wouldn't. And I'm sure we could organise a trial, and it would be worthwhile. My main worry would be that with Meniere's disease, if you wave a magic wand at a Meniere's patient, about 60% will have what's called a remission. So there's many, many ways of getting a remission, which means that the patient goes symptom-free for a while. So it's quite important in any study to follow them, and the American Academy suggests that you have to follow for at least 2 years before you can really be sure that it helped. My worry would be that low-dose gentamicin may only produce a remission, and we don't know how long that remission would last for. So I think the jury's out, John.
Oh,
you
no,
might be right, you might
I'm
be
sure
wrong.
it's out. But I don't know that I can persuade my patients to submit to a procedure in which I'm saying, I don't know if I'm giving you the active ingredient, or you may be just the experiment. Now, I don't think I'd have many patients who'd front up for that. Maybe you would, John.
You'd be surprised.
Well, I think if we put the argument, the discussion to the patient appropriately, I think most people are sensible enough to realise that we're trying to give them some relief, but we don't want to fall into the mistakes which have happened over the last 100 years of giving treatments which don't really work, and we still don't know whether what we're giving them is working. We're only telling them it may be. Let's all get together and try and sort it out. The other, again, compounding factor is we treat one ear, in nearly 50% of cases, given time, they're going to get Meniere's in the other ear too. So whatever we do to one ear, we've got to be, and particularly with balance, if we take, say, the engine off one wing of the plane to steady things up, we've got to be careful that the other engine's pretty healthy before we start mucking around with it. Because if you've got one engine to fly with, if that goes, you're really sunk.
Okay.
It worries me just a little about sac removal, Bill, in your operation when you take the sac out and they get it in the other ear. What do you do then? Do you take the sac out again?
No. I'll defend myself, but I don't want to get too waylaid on Meniere's. In Meniere's disease, what happens is that they go through these different stages that John mentioned. And if somebody goes through all the stages naturally, what eventually happens is the endolymphatic sac ceases to function, and they're left with a moderate severe hearing loss and about 50% of their balance. Now, the great advantage of removing an endolymphatic sac as a treatment over giving gentamicin to ablate vestibular function or cutting the nerve is that after you've removed the endolymphatic sac, they reach the end stage of Meniere's. They have 50% of their balance remaining in that ear, and that is the one big advantage over sac removal compared with other forms of surgery. I'm not suggesting everybody needs surgery, but it has the advantage over nerve section or giving big doses of gentamicin that you only follow the natural history of the disease and you're left with half your balance. Okay, we ought to talk about tinnitus, yeah? Yes?
Hello? It's an update on the results of tests and usage of that drug overseas.
Well, I know that they are still using it in San Diego. And I know that they are still using it in Germany. And a different sort of drug, but related to it in Vienna. We have not used it in this country because we haven't received the clearance from the appropriate authorities in Canberra. And I can't get the drug, even though the chairman of the committee that makes these decisions is the professor of pharmacology at my hospital. You would think that I'd have more chance than anybody of getting it, but I still can't get it because I think it's a financial decision. I think so.
Okay.
And it's certainly not available in Australia.
There's no news, sorry. Frank?
Yes, for my wife. She's had carotid artery operation. There's been a couple of them, and the surgeon has said you can't go up any further. And after that, she's got a tinnitus, and she's asking if something can be done. Thank you.
When did she develop the tinnitus? How long ago? Oh, 10 years. Okay, 10 years ago, Tony Crittenden.
Oh, okay.
Okay.
I thought I was off. I thought that was a purely medical question.
Ago.
Okay. Yeah. Okay. You don't think anything medical?
Not after 10 years.
No.
I think that will be.
I guess it's probably time to look at the management strategies, I guess, for your wife. So perhaps through an ENT or Concord or St Vincent's Hospital, get in touch about what can be done to help with the tinnitus itself, with the sort of management strategies. And the only positive thing I can say is people who've had the problem for a long time become convinced there's nothing can be done, and there are things maybe can be done without offering out too much hope. But I would follow it up, and it could be device related, and it could be backed up with, relaxation and other strategies. But we'd have to know the full clinical picture there.
Do John or John want to mention anything?
Oh, the drug.
Well, I was going to just explain what the procedure was that this gentleman's wife had. She underwent a replacement or a a reaming out and opening up of the major blood vessel to the brain. Now, if that major blood vessel has reduced diameter, no doubt lots of other little ones have as well. So this lady will have poor circulation in many parts of the body, and it might limit the benefit of medications, but it certainly won't limit the benefit of some other mechanical or auditory device to help her.
Thank you.
Yes,
Bill? Yes, go for it.
No. I was just admiring John's treatment.
Thank you. We have reached lunchtime, but one more. This is the last one.
I'm flying to Melbourne this afternoon. I've got tinnitus in one ear. Now, should I do nothing? Should I put earplugs in both ears? Should I turn my radio on so I get some white noise from the radio and keep my hearing aid in my pocket? What would you advise I should do?
From my experiences in flying with the plane, they're very noisy areas, and I'm sure there is any amount of white noise there anyway. So my inclination would be to put your hearing aid in your pocket and try and have a snooze.
I must point out that flying to Melbourne is very dangerous, because flying out of Melbourne is when I had a cold, was when I actually developed tinnitus in 1993. So I've got sympathy with that question. You should make sure, I'm sure John will agree, you should make sure that he doesn't get a blocked ear on the flight. Yeah.
You should look after your eustachian tube, in other words. Make sure that opens and closes with ease. Now, there's one other question. This lady here. Would you better have this? I can't hear it.
Finally, Maria says the earplanes are great. She tried them herself. These are little earplugs that have a little bit of cotton wool in them, and if the pressure should suddenly change, the little bit of cotton wool moves and it cushions the effect on the ear. They tell you you can only use them once, but if you poke the thing back up with a little pin. Okay. I think that probably is the, we should move, one more.
Is tinnitus hereditary?
Well, yes, there are some forms of hereditary deafness that also is accompanied by tinnitus. I haven't, so I know what you mean.
Yes. Yes,
Sure.
definitely. Well, thank you very much to the panelists for coming and enduring that. Thank you very much for everybody for listening. Thanks.
I'll just let you know, I'm actually the psychologist on staff at the Hearing and Balance Centre. And as we're aware, some people are not bothered by the tinnitus. The tinnitus is in the background and they say they very rarely notice it. And some people find it very distressing, annoying and very debilitating. This can result in problems with sleep, problems with interacting with their family because the person's irritable, problems with productivity at work are some of the things that people talk to me about. And there's many other ways that tinnitus affects people. And I'm sure everyone here is aware of those ways that people are affected. And this can result in anxiety and depression. And tinnitus can be perpetuated by being told that there's no cure for tinnitus, you just have to learn to live with it. And we call that negative counselling. Just out of curiosity, how many people have been told that here? Okay, so that's a lot of people, 50% of the room. Okay. And that makes it even more devastating to think that you have to learn to live with the tinnitus, yet you're given no reasons or any ways of how you can learn to manage your tinnitus. Today I'm going to talk to you about some interventions that can help with tinnitus management. Importantly, how we understand tinnitus. In the past, we understood tinnitus, that tinnitus was produced from the cochlea, which is the source of the tinnitus, our hearing mechanism, how we hear sound. And how it used to be treated in the past was by fitting devices such as hearing aids or using maskers was another form of intervention, and also medication was used to help treat the source of the tinnitus. But in the last 13 years, we've become aware not only of the source of the tinnitus is from the cochlea, but also parts of the brain, as we've heard today over and over again, parts of the brain maintain the tinnitus signal. And that is a very big advance in tinnitus management. And what that's resulted in is a holistic approach to tinnitus management. Medical, audiological, and also psychological interventions in relation to managing tinnitus. Some interventions that can help retrain the brain from tinnitus include tinnitus retraining therapy, which we've heard, like I said, over and over again. And that's very positive that most of the doctors here today have spoken about tinnitus retraining therapy, because it means that there's an acceptance of tinnitus retraining therapy, and we see the importance of the brain's role in maintaining the tinnitus signal. Cognitive behavioural therapy, and also hypnosis. And I'm going to talk to you about those interventions today. Tinnitus retraining therapy was proposed by Dr. Paul Jasrubov, who's a neurophysiologist, in 1988. And some of this I'm going to go over, like I said, people have mentioned it today, the doctors have mentioned it today, but I'm going to just go over and reinforce it with you. It's based on the neurophysiological model of tinnitus. And its aim is habituation. And when we talk about habituation, we talk about the tinnitus being there, but you not being aware of it. And an example of that would be, a lot of people have, well, everyone has a fridge at home, and the majority of people won't hear the sound of the fridge motor going, because they've habituated to it. It's not a threat to them, so then they don't pick up the tinnitus, the fridge sound. It's just in the background, and on occasion, they might be aware of the fridge motor. And that's the same process of habituation in relation to tinnitus. That's the aim. Okay. Now, if we were to look at the neurophysiological model, and this is developed by Paul Jasrubov, and I should let you know, Dr. Jonathan Hazel was one of the first ENTs in the UK to actually implement this in his private clinic with very good results. And as we can see, the source of the tinnitus, as been spoken today, is from the cochlea. So we hear tinnitus signals in the cochlea. It's detected in the subcortical area of the brain, and it's transferred by the brainstem up into the auditory and other cortical areas of the brain. It's perceived and evaluated. And what happens there is, as has been said before, it's perceived and evaluated, and then what happens is it's then the limbic system has an emotional association to the sound. And what happens in relation to tinnitus, the limbic system is like a filing cabinet, and it associates emotion to sound. And with that filing cabinet, what happens is, there's a negative association to the sound, it will continue to pick up the tinnitus signal and be detected and perceived and evaluated in the brain. And I should also point out that you don't actually hear sound until it reaches the auditory and other cortical areas of the brain, where it's perceived and evaluated. And then we have the negative association and negative emotional association to it, and then it keeps being detected and evaluated in the brain. An example of the limbic system being in place would be if I said to you that I was going to run my fingernails down a chalkboard. People would often just cringe at the thought of that, because there's a negative association to that sound. And that's a similar thing with the tinnitus. With it being picked up in a negative way, again, it keeps coming up to the brain and being reinforced in the brain. And what happens is, once that negative association occurs, it triggers another part of the brain which is known as the autonomic nervous system. And this autonomic nervous system is known as a fight-flight response. And we know that is involved in stress and anxiety. And once the fight-flight response is triggered, people will experience symptoms of anxiety such as they might have muscle tension, feeling anxious, the fear that they feel about the tinnitus, problems with concentration, a whole lot of problems that occur with this being triggered. And with the autonomic nervous system being triggered, we know with the autonomic nervous system that it's like a radar. It will start to monitor sound or anything, that the brain will actually start to monitor anything that it perceives as a threat when the autonomic nervous system is triggered. So it doesn't even have to be sound. But in relation to the tinnitus, because of that negative association and then the fear and the trigger of the autonomic nervous system, it becomes like a radar and then continues to monitor the tinnitus signal because it perceives it as a threat. And that's where people complain of having constant tinnitus. And what actually happens once that's triggered is that it then keeps being picked up and perceived and evaluated, so it's constantly monitored. Now, Jasrabov proposes there's two links here that are occurring. So we've got this happening, this cycle happening over here, and we've also got this happening here with the limbic system being picked up, perceived and evaluated. Okay. I'm not going to go into great depths of the model because it involves counselling and explaining it in detail for the person to understand as to how tinnitus occurs and then how to break those two cycles. But I will briefly overview it. Okay. In two parts. TRT involves two parts. The first part is directive counselling, which I provide at the Hearing and Balance Centre, and the other part is what we call auditory therapy. Jasrabov does actually call it sound therapy, but there is another form of treatment that someone mentioned before where you can actually buy tapes and listen to music that they've taken the high frequencies out of. So we actually call the sound therapy component of Jasrabov's tinnitus retraining therapy auditory therapy, so there's no confusion. Directive counselling involves explaining to the person neurophysiological model in depth. Again, I've just briefly gone over it. And also talking about how tinnitus retraining therapy itself helps retrain what the process is and how it helps retrain the brain from picking up the signals and reducing the activation of the limbic system and the autonomic nervous system. Directive counselling also includes auditory therapy, so actually giving advice about auditory therapy such as hearing aids, noise generators, so that is part of the process, and also how to introduce sound into the environment. And what actually happens with actually explaining to the person that has tinnitus what the process they're going through and how this occurs and how you can reverse it, this results in reversal of the negative counselling that I spoke about before. That it changes your belief that there is something you can actually do for tinnitus, which you can. And what happens with directive counselling is it actually decreases the level of the stimulation, the cortical areas of the brain where the tinnitus signal is being perceived and evaluated, to the limbic system that I mentioned before, and also the autonomic nervous system. So it actually reduces that neural activity occurring. And what that results in is what we call habituation of emotion, where the person has a what we call neutral emotional association. And actually Jonathan Hazel talks about befriending your tinnitus, or to believe that to perceive your tinnitus as being music to the brain, that it's not going to hurt you, that it's just music to the brain. And with habituation of motion, because you're not reacting to it, you just accept it, what actually happens is you then get habituation of response. The autonomic nervous system is no longer being activated, highly activated, and then you don't fear it, you don't get angry by it, you don't get depressed about it. I must say with directive counselling it does take time, and people quite often say to me, but how am I ever going to befriend my tinnitus? But it does occur with time. The second part of tinnitus retraining therapy, which is important, both parts are important, that you need to do both parts, not just one, but to do both the directive counselling and the auditory therapy. And auditory therapy involves the appropriate use of sound in your environment. And that's done by the use of hearing aids, which Celene's talked to you about today, and also noise generators. Hearing aids are used for people that have hearing loss. Noise generators are used with people that have normal hearing. And that it's really important to have sound in your environment, because whilst you don't have sound, what do you pick up on? The tinnitus signal. And that strengthens the neural activity going to the brain. So what we want to do is to try to reduce that neural activity. And by utilising sound in the environment, what you're actually doing, you're reducing the difference between the tinnitus and the environmental sound. So the tinnitus signal going to the brain is actually weaker. And again, that stops that perception and evaluation, and then the strong neural activity to the limbic system and the autonomic nervous system by doing that. And there's also other devices you can use for noise generators. To introduce noise in your environment is important. And some people here have probably got the Conair sound therapy machine, which is a neutral constant sound. That's one way of introducing sound into your environment. And it has to be neutral and constant. It's important to help reduce that contrast and retrain the brain. And again, what happens there is, with using sound and reducing that neural activity, what happens, you get a habituation of the limbic system. Again, you're no longer, you have a neutral association because you're not just hearing the tinnitus signal, it's reduced. So then you start to have a different memory bank about the tinnitus. You're actually tricking the brain away from the tinnitus signal and getting it to reprocess it in a more positive way. And also what happens is, too, with that changing in the neutral association, emotional association, we get what we call is, again, neutral reaction. You, again, not fearing it. If you become more accepting of it, the tinnitus signal eventually weakens, and your perception of it as well. This has been said before today as well, but it is really important to stress this. An important rule of auditory therapy is avoid silence. Really, really important. A lot of people find that the tinnitus is so bad and they think, if I just stay in some quiet, this is going to help my tinnitus. But it is the worst possible thing you can do, to be in silence, because all you're picking up is that tinnitus signal, and it actually strengthens the signal going to the brain. Okay. With habituation of emotion, again, neutral association, refiling, recoding tinnitus signal to be something like the fridge noise I mentioned before, where you hear it but you don't respond to it, you just have a neutral association to it. And habituation of reaction, not being fearful of the tinnitus, accepting the tinnitus, not getting angry at the fact that you have tinnitus, results in what we call habituation of perception, where again the tinnitus is there, but you don't hear it, or you hear it on occasions, just like the fridge noise. Just to reiterate too, tinnitus retraining therapy is not a cure as such. And if we think of what was discussed before about everyone having tinnitus, the reason that people that don't hear the tinnitus are not bothered by it or don't hear it is because they have habituated to it. We have a number of sounds from early on when we're born. We have sounds of blood going through our body, our clothes on our body. We don't pick up those sounds. As we go along in life, we habituate to it, we get used to that. So then, and because it's not important to be monitored, we don't hear it, or we don't pick up on those signals of the hearing, the blood flowing through our ear, or our clothes on our body. Tinnitus retraining therapy can take up to 18 to 24 months, according to Jastrabov's studies and studies done around the world. and this is for optimal results. That doesn't mean that you see someone for the 18 to 24 months on a regular basis. That depends on what your needs are as to how often you see the person. And it can be less time. Some people find, I've seen people for a couple of sessions or even 3 sessions, and they've had dramatic change in their perception of their tinnitus because their attitude and outlook about their tinnitus has totally changed. And also there is, with research around the world, it's been shown that there's an 80% success rate. Though I need to point out, with the research that has been done around the world, there haven't been any control studies. And when we talk about control studies, controls are where the person hasn't gone through the intervention, and it's been the controls are then tested against the people who have gone through treatment. But with 80% results, that's very positive. The next thing I'd like to talk to you is about cognitive behavioural therapy, which is based on Aaron Beck and Albert Ellis's work. Cognitive behavioural therapy has been used to treat people with a number of chronic conditions, chronic pain, anxiety and depression, with very good results. It is the most successful evidence-based form of intervention, psychological intervention to date, and results have found that there's on average 75% positive outcome from people that have gone through cognitive behavioural therapy in them managing their pain or reducing anxiety and depression. And recently there's been research in relation to cognitive behavioural therapy and tinnitus management with very positive results in resulting the person reducing their distress and their annoyance in relation to their tinnitus. What cognitive behavioural therapy involves is the importance of our thoughts and beliefs in the way we see the world, see ourselves, the world, and also our future. I'm going to talk to you today about Ellis's ABC model. And again, I'm not going to go in great depth about how CBT works, but to just give you an overview. Ellis's model states that if we look at A is the event or the situation. We have an event or situation that occurs, and that results in B, how we think and our beliefs about that situation that's occurred, which results in feelings and behaviours. Okay, so when an event occurs, we think about that event, we have what we call autonomic thoughts, and we're not always aware of those thoughts, and that results in the way we feel and behave about a situation. You're probably wondering how this relates to tinnitus, and I'll give you an example. Okay. Quite often with tinnitus, the thing that I see with patients is that they become very negative about the tinnitus, which again is understandable because of the negative counselling they've had, that there's no cure for tinnitus and there's nothing they can do for the tinnitus. And they become negative and they have a sense of hopelessness. And just to give you an example of negative thinking, we have an increase in the situation, based on the model that I spoke about just before. There's an increase in tinnitus. The person thinks to themselves, my tinnitus is so bad, I can't go out to dinner tonight, there's nothing I can do, I can't cope with this unbearable noise. So the thinking's negative. And what happens as a result of their negative thinking, they feel anxious, they feel depressed, and they'll withdraw from social contact, so they won't go out to dinner because they just feel they can't cope to go out to dinner. What cognitive behavioural therapy aims to do is to help you change the way you think about your tinnitus and to make your thinking what we call more constructive, or some people call it positive. Okay, so it's the same situation, but this time the person thinks to themselves, my tinnitus is loud and it's making me feel bad at this time. When I went to dinner the other night, it was loud initially, I coped, and at times I hardly noticed it. Dinner tonight will be a good distraction. And that results in the person being calm, accepting their tinnitus, and going out to their dinner, having social contact and having that distraction. So instead of being anxious, and anxiety triggers the autonomic nervous system. Anxiety is our flight-fight response, which is when adrenaline is released from a part of the brain and we have anxious symptoms. So instead of that happening, we have a more constructive way of looking at things. And this is a process. It's a process of learning strategies. Some people say, but I am positive. But you've got to believe in what you're saying to yourself, because if you don't, it won't have an effect. So the process of CBT is teaching the person to challenge the way they think and gather information, and a whole lot of other strategies to change the way they think about their tinnitus. Cognitive behavioural therapy helps the person identify their thinking style and beliefs, and also the effect on their feelings and behaviour as a result of their thoughts. It provides the person with strategies to challenge negative thoughts and convert them to constructive thoughts. And this is done by going through a process of getting the person to look at the validity of their thoughts. And it can help manage tinnitus. And people will say, but how can cognitive behavioural therapy help with the management of my tinnitus? Again, it's changing the way you look at your tinnitus. It's getting you to become more accepting of your tinnitus, and it helps actually with the habituation process. Because if you remember, we looked at the neurophysiological model where we looked at the limbic system and the negative association. It allows you to become more accepting of your tinnitus and helps with that process. Okay. Some other cognitive behavioural interventions that are useful are thought stopping, because that's a strategy that actually helps stop negative thoughts. Distraction, and people quite often do distraction anyway with doing different activities. And the interesting thing is, when most people are really focused on what they're doing, they don't notice their tinnitus. And the reason being because the brain can only keep a focus on one thing at a time. Creative visualization, which is using imagery to assist reduce tinnitus, and again retrain the brain away from the tinnitus signal. And relaxation, and there's different forms of relaxation, like progressive muscle relaxation, which is tensing and releasing your muscles, and also deep muscle relaxation, going through the body and releasing all the areas of the body. And relaxation actually involves mentally and physically relaxing the body. What that does is it reduces stress. And that's important because we know that when the autonomic nervous system is stimulated, you're going to be picking up the tinnitus signal, and relaxation can help reverse stress, or I should say manage stress. Also, I forgot to mention, with cognitive behavioural therapy, it is also very useful. The interventions that I just spoke about before are very useful in helping people with sleeping problems. And at this Hearing and Balance Centre, we see a lot of people that have sleep problems as a result of their tinnitus, and implementing those sort of strategies and with other information about sleep, you can get a restful night's sleep. Hypnosis. Now, people quite often associate hypnosis with stage hypnosis, where someone gets up on the stage and performs and hypnotises a person to go and run around like a chook, or take their clothes off, or do some strange things. But in a therapeutic sense, it's not used that way. And I just wanted to let you know that. I'm not going to do any of that today. The hypnosis in a therapeutic environment has been used for a number of health problems, such as blood pressure, people that have blood pressure, to help reduce their blood pressure through relaxation. Also, some people may have given up smoking through the use of hypnosis. Okay. And there's mixed research about the effects of hypnosis. But what I find in using hypnosis in relation to tinnitus management is that for some people it is very, very useful. And what hypnosis actually involves is with someone that is skilled in doing that, you're actually narrowing your focus of attention down by relaxing. Okay, so the therapist actually relaxes you. You narrow your focus down so you're not taking in out on any external cues, such as the noises outside. What that actually allows is the barriers that you put up when you're in a conscious state, it allows you to lower those barriers, and the therapist then gives you positive suggestions. And I give people positive suggestions about relaxation, about turning the volume control down on their tinnitus, about visualization, and also changing their thoughts, actually doing some cognitive restructuring whilst under hypnosis. And what that does is, it actually, thinking back to the neurophysiological model, it actually does all the work below with the limbic system and the autonomic nervous system. The subconscious, as Hazel says, can actually reduce the neural activity occurring in the subconscious. So hypnosis is useful for relaxation, to actually change your thoughts about your tinnitus, and distraction, and creative visualization. Okay, and that can help with the habituation process again. Okay, I must say too, because I'm the psychologist on staff, and just to let you know, and I was going to say this initially, but I forgot to. As a psychologist, I don't think that tinnitus is a psychological problem. It's not. Tinnitus is a symptom. And people quite often think, well, why am I going to see a psychologist? The reason psychologists are useful in that they can teach you strategies to help with the habituation process. And I've actually had training with Dr. Pal Jazarabov in tinnitus retraining therapy as well. And by using a combination of approaches, because everyone is an individual. That's the other thing. Psychologists believe that everyone is an individual. And the tinnitus affects people in all different ways. And the treatments that I've spoken about today, the interventions I've spoken about today, may not be useful for everyone, but they can be modified to each person and what their needs are. And what happens is, what I notice as people go through the process of our tinnitus program is they actually become less aware of their tinnitus, or their tinnitus is there, but they just don't notice it. They're not bothered by it anymore. They're not distressed or annoyed. And they have longer and longer periods where they're not aware of their tinnitus. And again, I've mentioned this before, but it's important to see the change that we've had with a holistic approach in tinnitus management, medical, audiological, and also psychological. Okay. In some instances, I must say that some people come and they are suffering from severe anxiety and depression, and it's very hard to implement tinnitus retraining therapy and cognitive behavioural therapy and hypnosis. And in that case, the person, it's valuable for the person to go and see a psychiatrist to get some medication whilst they are going through the treatment program. And Professor O'Sullivan is going to talk to you more about that today. Thank you.
A couple of questions just for Maria first, and then we'll move on to Brendan.
No one has any questions?
Unless you did it so, no, I think it's just they just need a moment to get ready and queue up.
Thank you.
Can you tell me what the cost is of this tinnitus retraining therapy, and is it available in New South Wales country centres, please?
The cost varies from person to person. We are a private clinic, but it depends, because like I said, some people just need one session, or they may need a number of sessions, so that varies. As to whether it's available in country towns, the only place in New South Wales that has clinics is Concord Hospital and Hearing and Balance Centre at St Vincent's Hospital, that have people that are trained and qualified to implement TRT. As for people in the country, I actually do telephone consultations with people. They might come down initially to be assessed, but then with the ongoing process, I actually have phone consultations, which I'm happy to do. We actually have people interstate that come to us and also have phone consultations as well as part of treatment. So again, and that's where the individual needs of the person is addressed.
Maria, I think it's really great that you are promoting this holistic approach, and you certainly talked about quite a mixed bag of psychological approaches, and I think obviously as a psychologist you'd be bound ethically to provide your patients with empirically validated treatment approaches.
Yes.
You mentioned that TRT doesn't have, there are no controlled studies. The data is not there. Which of the approaches does have the strongest empirical support?
Cognitive behavioural therapy.
Why would you then choose TRT? Because you spend a lot of time talking about TRT.
Because the problem with TRT, the difficulty, TRT, as you've heard all the ENTs speak about TRT today, it is the most successful. I find it, the person can actually change through the process. I've actually seen that myself. The difficulty with actually having control studies is if you're in a private clinic, it is very difficult to implement controls, to put people on waiting lists and not tell them when they're so distressed that they can have intervention. There's ethical issues there as well. And to date, there haven't been any. They are trying to do some research over in the UK with that, within a university environment.
I think it's just important to really emphasise that the data is still not in. We're still waiting for that hardcore empirical evidence.
Yes. We are.
Yes. We're still waiting for the hard data about penicillin. Never went through a trial. But, you know, it's difficult because, as Maria says, it's hard to design a good study here, but I think they are going to do one. Yes, it'll come. Yeah. Thanks, Maria. Thanks very much. Let's some more questions later. Yeah, thanks. So I thought we should try and keep vaguely on time. So the last speaker is Professor Brendan O'Sullivan, who's at RPA, and he's, for some extraordinary reason, when he was a medical student, he stayed in a hostel of deaf people where they used visual communication. And since then he's taken hearing and the problems associated with hearing to heart, and he runs a special clinic for people who have hearing problems at RPA. Brendan.
Thanks, Bill. Well, thanks for everyone attending, and to the, I'll leave it there. Yeah, and for the ATA to invite me. The sort of people, I might use that because later, because I don't want to be left out with my boxes and arrows. Everyone else seems to have used them, so just leave it there because it's quite visible. Well, my involvement with tinnitus people came rather indirectly, and people who suffer tinnitus suffer badly. That was quite evident to me early, and it's worth an anecdote, even though it's not a double-blind crossover trial. The anecdote was when I was a medical registrar at RPA working in emergency, and this young fellow came into casualty with bleeding ears. And in fact, we did find out that an instrument like this had done that as he gouged his ears, trying to get rid of the tinnitus. Now, that's a fairly horrendous story, but tinnitus has enormous psychological, emotional impact on people. And it occurred to me at the time, this must be quite an extraordinary symptom to have such an extraordinarily self-destructive result. I also came into tinnitus from deaf signing people. Of course, most deaf people, who, if they're born deaf or deafness from an early age, they don't have too much tinnitus problems as a rule. You actually usually have to have quite a bit of hearing in the early years, and it's the acquired hearing loss people who become deaf later in life who had dreadful tinnitus, and the most difficult of all the problems that I came across in those early years. So by way of introduction, I have to thank all the patients I've seen over the years, because they've taught me a lot about their symptoms and the best ways to approach the problems and how not to approach the problems. And as an interested medical student, I went searching through textbooks, medical textbooks about tinnitus and other similar hearing disorders, and of course there is no textbook, and one has to learn most of these sorts of skills as one goes. I'd also like to make a comment based on Maria's, or the question put to Maria, that medicine has always been both an art and a science, and that it doesn't always have to have complete, conclusive proof in order to be an effective form of treatment. Okay, so most of the work that I've done with tinnitus people, I'll try to sort of summarise a little anecdotally, but and not to repeat a lot of the work that has crossed over from the different speakers here. It is interesting, isn't it, that the range of people who are interested, or medical professionals and other, who are interested in dealing with tinnitus come from many different disciplines. That's because tinnitus can't be managed within one single discipline. You need a good audiologist to make sure. You need a good ENT to make sure there's no biological problem. You need counsellors. Sometimes you need psychiatrists. Now, the sort of people that I see are those who have not done well with tinnitus retraining therapy, or had some reversible, remediable medical condition. And there are a wide range of people with tinnitus who eventually come to my door. The typical problems that I encounter have already been covered by previous speakers. I have to say that the worst possible thing the medical profession can do is give that negative counselling. There's nothing that can be done. And I can't tell you how relevant that is. That should be signposted to every ENT in the country and every GP and everyone else, because it takes an enormous amount of time to undo that damage. You know, this is part of the the Hippocratic tradition that says, above all, as a doctor, do no harm. I think that bit of advice does just far too much harm. The people who also come with a range of symptoms, and depression is typical. The young fellow who was gouging his ears had what they call an endogenous depression. It was a serious psychotic depression where he'd lost touch with reality. But most people come with lesser degrees of depression. A number of other people come with an exaggeration of some previous difficulty. Somewhat obsessional people, for example, when they are ill from any cause, become rather heavy checkers and counters. So you can find a reaction that is really an exaggeration of pre-existing personality difficulties. You find people who develop depression of different degrees, right through to suicidally intent people, and also a number of anxiety disorder problems where people develop full panic attacks where there's extreme autonomic arousal. That means, in lay terms, palpitations, shortness of breath, tingling in the fingers, over-breathing, sweating. And the most common, however, problem that I encounter is the individual who has themselves decompensated in some way. And in other words, what I deal with predominantly are not mentally ill people, but normal, ordinary people in extraordinary circumstances. And there's a number of factors which make those circumstances more extraordinary. If there is additional loss, such as hearing loss, if there is a major shift in the family dynamics, for example, the breadwinner becomes deaf through industrial causes, and if there's compensation issues there, if there's deafness, the quality of the tinnitus, if it's pulsatile or one ear, or it goes in crescendos, or it's strongly stress-related, a whole range of things which make the perception of the original tinnitus worse, and the consequences in terms of how it's meaningfully ascribed, if you like, worse as well. So quite often it's a family in a family or a system problem. And it's not at all uncommon to end up treating the spouse and counselling, if you like, in Alzheimer's patients, caring for the carer. So things aren't always as they seem. And I think one of my roles is really just to sit and listen and dissect out what the various issues are. Now, part of the problem, I suppose, with our system is that through the 70s and 80s, medicine became more and more specialised, and there were masters of certain trades, but jacks of none other than their own. So the problem is hyper-specialisation, so that it's difficult to talk across disciplines. And you see from the speakers today where Tony Crittenden spoke eloquently as a psychologist, who was an audiologist, that we need to talk across disciplines and treat the whole person, as Maria was saying, with a realistic approach. Now, the best that I can provide for a situation I have learned from my patients is to sit and listen and to understand. So being understood is the first and most important psychological intervention. And secondly, to be believed, because tinnitus, like mental illness, has one similarity, and that's it's invisible. Only the consequences are felt so intensely. And because it's invisible and there's no X-ray to hold up, and broken bone to point at, people don't understand, and they're less likely to view it as justifying the emotional consequence, or they point to some personality weakness or moral judgment which accounts for the repercussions of the disorder. So to listen and to understand, to feel understood, and to dissect out the various components that is tinnitus. Now, tinnitus has many different aspects, and I'm just going to descend the stairs for half a second to just scribble up a diagram. Well, the reason for putting that up is to remind me always that these sort of components interact in a holistic approach to individuals, and that anything that is a model that is short of these three interacting components of biological and psychological and social won't do justice to the situation. So the first thing is to ensure that people really have had adequate assessment from an ENT, have had correct advice given, have seen an audiologist. Many who get to me haven't. And so I have to go back and make sure that all of these things are done and that all the necessary physical treatments are in place. And also to interview family and other members who are affected. See, one person is immediately affected by tinnitus, but it's almost always a whole family that has a disability because of it. So anything short of looking at that whole system is not doing justice to tinnitus in the people that I see. Now, apart from defusing some of the negative counselling and demystifying what tinnitus is, it's extraordinarily important to be reassuring, if it's appropriate to reassure. Many of the people do come believing they have a brain tumour, even though prior to that meeting they've told their doctor and everyone else that they believe they do not. And that's a surprisingly tenacious belief that there's something organic that the doctors haven't quite got right. The next thing is really to ensure that there is some sort of diagnosis. Now, occasionally this is quite obvious. A person who has panic attacks and is fearful, believes they have a brain tumour and has panic attacks, is readily treated. People who have a history of anxiety disorders or have gone through a rather traumatic series of events leading to their tinnitus have many of the features of so-called post-traumatic stress disorder. Although they've never been to any war, they feel they've been through one, usually with aspects of the medical system or finding out a diagnosis, etc., and ultimately finding out there was so-called no help. Now, the common features of PTSD are nightmares and sleep disturbance, an increased level of arousal and anxiety, and or panic attacks. Unfortunately, PTSD is relatively easily treated. So it seems a great sadness to me that a number of people I've seen have had PTSD symptoms for 10 years plus for want of seeking help earlier. Virtually everyone gets better from that sort of situation within a few months. Now, the next most important group of people that are depressed. Do you know anyone who's had tinnitus that hasn't been substantially depressed? Why it's so closely linked to that emotional response, one can imagine. But many do speak of a loss. Some people, as though someone has died. A loss of, for young people, of dreams, hopes and expectations of the future. A loss of uncertainty for a rather more obsessional, controlling person. A loss of relationship, power relationship, a loss of job, and for some people just a loss of silence. But whatever the loss goes with depression as a reaction. And it's only when depression becomes more that they usually end up seeing me, because people can be depressed beyond all reason. In the old days, they would call that a nervous breakdown. And most of us, at least 20% of us, will have experienced a depressive illness in our lives. In fact, depression is the most common illness suffered by all Australians. About 20%, that's what, 3.5 million, will have episodes of depression through their life. And by the year, was it 2020, the projected incidence of depression will be higher than all other diseases. When depression goes beyond sad and blue, it ends up tying up the whole biological system. And the belief is that the sustained arousal from the flight system, which has been described a few times here, leads to a complete change in the brain chemistry, where so-called catecholamines, serotonin, noradrenaline fail. And that leads to some really weird symptoms. It leads to a sleep-wake cycle disturbance, where people often can get off to sleep. Okay, they might have initial insomnia, but at 2 and 3 in the morning, 4 in the morning, they keep waking up inexplicably, because the sleep-wake cycle is also controlled by catecholamines. They lose interest, they lose energy. And this is something that's hard to explain to someone who hasn't experienced it, but people often do talk about a mental paralysis, where they wish to touch this item here, but they can't actually will themselves to do it. They can't actually move. Occasionally you'll see old ladies and other people in psychiatric wards who are frozen into inaction. They simply can't move. So psychomotor retardation, or slowing of thinking, concentration and memory difficulties, early morning awakening, loss of weight, feelings of hopelessness, helplessness, worthlessness and guilt, which can go from normal through to psychotic. One tinnitus patient had the firm conviction that they had in some way instigated World War II. It was very difficult to convince them, because they were in such a self-blaming, delusional state that it wasn't amenable to correcting with any degree of logic. So depression could become extremely serious. 2,500 people suicide every year in Australia. And if you think of a football stadium, that's a lot of people. Almost 90% of those would be readily correctable with treatment for depression. The extraordinary thing about depressive illness, unlike a lot of medicine and unlike tinnitus, is that depression is almost 100% treatable. If it's identified early, people seek help. And it usually means some tablets, some talk, some time, and often some lifestyle action. So for a disorder which is so common in tinnitus and so completely treatable, it's extraordinarily sad that people who develop serious depression don't get help. I've noticed also the problem when people do develop depression, they're even more aroused and susceptible to tinnitus. So they go into this sort of cycle of tinnitus versus depression, depression causing tinnitus, and down they go very rapidly. So there's a kind of an interaction here between the psychological consequences of tinnitus and the biological response of the limbic system, which feed off each other. And how the social connectedness works in there is as individual as every tinnitus sufferer. It depends on where they are in the family, where they are in terms of the power relationships in the family, what changes as a consequence of tinnitus, how stable was the marriage, all sorts of other issues which come to light when tinnitus, or I suppose any other disability, hits, but may have been compensated for and dealt with to some degree before then. So there are people who have difficult previous situations which are unmasked by a disorder such as tinnitus, and there are normal, regular folk who are otherwise coping well who fail to cope adequately with an extraordinary situation. And all these things need to be teased apart. So having taken a history from someone with tinnitus, the next thing is to kind of review it and to say, well, look, what are all the various components contributing? And almost always, half of the contributors can be dealt with. One doesn't need specialised medical training for this. It's really just common sense. But the common sense that a third person, an objective third person, can apply, whereas when people are caught up in the fury of tinnitus and family dynamics, one can't see them. So some common sense goes a long way. Some psychoeducation about what tinnitus is, what depression or anxiety is, what the interrelationship is, what the value of talking therapy is, what the value of medicines are, etc. Helps to debunk, demystify and defuse a lot of the issues which were pent up at the beginning. Now there's a role for physical treatments, as we've just heard, and most important thing is to make sure that adequate access, that person has had adequate access. So it's not uncommon for us to cross-refer between each other. When it comes to the subject of medications, it's a moot point. I noticed there was some scepticism and concern about medication raised by some of the speakers and also in some of the conversations. A person who has classic endogenous depression, who has feelings of hopelessness, helplessness, worthlessness, guilt, suicidal ideation, and disturbed sleep, should receive medication. And the reason is that the risk of medication is far less than the risk of not treating. And there are 2,500 people each year, each and every year, year after year, to attest to that. And tinnitus sufferers are no exception to that, because in fact they're more prone to depression in my view than any other group that I've ever come across. All antidepressants are effective these days. I said about 90% of people are better within a few months. Doesn't mean the tinnitus goes away, but they can cope with it better. They're not in that sort of dark, deep hole of depression, so they can cope with more realistically with real life problems. In all of the antidepressant medication pamphlets that you see inside, you'll always see SSRIs, Cipramil, Arapax provided as potentially making tinnitus worse. But I think that the point was made by Neil or John that this is really to cover the drug companies medico-legally. The risks of developing tinnitus or tinnitus becoming worse on standard antidepressants is extraordinarily low. I've never come across it yet. But the risk of not going on to antidepressants is far too high and unacceptable, not just to that person but to family. So I'd like to make a plea for a little less over-concern about the effect of modern-day antidepressants. No antidepressant tablet is addictive, not one of them. You can't get so-called hooked on antidepressant tablets like SSRIs. Mostly they're not sedative, so you can't be zombied out. And the extraordinary thing is that they're 85% to 90% effective. So yes, you will get better. There's no doubt about that eventually. Tinnitus then can be dealt with in a more constructive and realistic way. Now there's two people who've had tinnitus that I know who have suicided. If there was a virus that hit our shores, we call it the human suicide virus, HSV, not HIV, and it cleared off 2,500 young and middle-aged and older Australians each and every year in the most miserable way to die, that is by self-inflicted death. And if this virus hit our shores this day, there would be a massive outrage. There would be research money pouring into the depression virus, and the Garvan Institute would be turned over to depression research. But that's what happens with depression, and yet it's so treatable. So that's my main point about depression and tinnitus. If you've got depression, and if you've got some of those symptoms, don't leave it to fate. It is really best to get help. Other medications are useful in tinnitus, and again there is concern about so-called Valium-type benzodiazepines. Drugs like Rivotril can certainly give short-term relief from tinnitus. In a very serious, acute tinnitus, which is totally intrusive into conscious thinking, that people really can't think of anything else. It just dominates conscious thought. Rivotril is a real lifesaver. But like all these drugs, they can't be used in the long term. So if Xanax or Rivotril or Valium or Gibson are used in short, sharp bursts, they're very effective at reducing the levels of tinnitus and anxiety in the short term. If you remain on them, however, they run out of oomph. They cease to become as effective, and you need to increase the dose, and then you've got problems. I've never come across a tinnitus patient who became addicted to any benzodiazepine drug, because mostly they're too cautious and they value life and their independence and control too highly. Generally, they're not the people who are likely to develop dependence, although one has to be cautious, of course. So I wouldn't rule out those medicines either. Someone mentioned carbamazepine. Tegritol is very effective in some people, but not if you put them on anti-epileptic doses, which is it's normally an anti-epileptic. Things like Tegritol, you go slow and you go low, and then monitor carefully response, and that's particularly effective. So medicines should not be ruled out, and I think there's been a pendulum shift against different medications, but not for strong and good reasons, to the detriment of some tinnitus sufferers. The tablets aren't the whole story. They just interrupt the sort of biological process of amplification through brainstem limbic system. Unless the whole person has other issues addressed in their lives, that will hardly be a great comfort to them. There's no doubt that people who have had tinnitus a long time have increased levels of anxiety and need some sort of stress management. There's no doubt that tinnitus retraining therapy works in helping people to rethink and habituate to tinnitus. The realistic aim in tinnitus is not total cure, that very little of medicine is aimed at total cure, if you think about it. It's aimed at ameliorating symptoms so that it is manageable, that life becomes manageable again. So I often try and redefine the aims of what we're talking about and doing as a kind of as a collegiate enterprise, that we are working on it together, and we have to work together to these certain aims. Now, the realistic, defined aim is to make life manageable again. It doesn't mean that tinnitus goes, it means that it's acceptable and you can work with it. It's a bit like grief. When someone dies who's important in your life, you never so-called get over it. That would be a slap in the face to the person who died. The aim is not to get over it, but the aim is to get on with it. And I think that needs to be accepted by both parties. Most important thing of all is to ensure that people are connected. Now, I know that everyone in this room is connected, but for every one of you, there was 20 people. There was another, Thelma tells me, there's twice as many who wanted to come. And of all those people, there was 20 times that number who saw the ads and thought, oh, that would be all right, I'd go to that, but I'm not here. And then there's 20 times that number again who have tinnitus that never saw the ad and not connected to anyone. So although we are here preaching to the converted, the truth is that we have an increasing obligation to go out and find, go out and seek, and go out and educate the community generally. Now, the ATA is invaluable here because the ATA is the only group that has organised themselves, a self-help group, to provide objective information and a sense of you're not in it alone. And since human beings are social beings, we're not individualists, we like to think we are, but we are entirely social. If we don't have that sort of sense of connectedness, we soon fail. So group therapy or group connections and self-help support groups are a cornerstone, I think, in dealing with what's left over, residual problems after patients leave my care. A number of people have got big issues. They need individual psychotherapy. And you'd be surprised, tinnitus sufferers are just like everyone else. They have a range of problems, from sexual abuse in the past to difficulties in accepting their identity, right through. And a number of people need a little bit more talk time. And finally, there's the advocacy role. Many tinnitus people, as you know, are caught up with medico-legal issues or workers' compensation. There's no doubt at all that the workers' compensation system does not recognise tinnitus adequately. Because it's not on the list drawn up by politicians and lawyers, doesn't mean it doesn't exist. But currently, if it's not on the list, it doesn't pay. So a role that I've been involved in more and more is in a sort of medico-legal advocacy role, right through from district up to Supreme Courts, trying to argue that tinnitus has major impact on the psychological well-being of people and is a necessary source of concern at the workers' compensation court level and other levels. The final comment, I suppose, is that although there's no cure for tinnitus, there's no cure for many things. But if you define the outcome as making life manageable again, it staggers me how many people don't end up with psychiatric difficulties, including psychotic depression. It's quite unbelievable, and it reflects well on the resilience and the strength of individual people who go through adversities of various sorts. So I have an enormous respect for people who can get on with life, who have tinnitus. But if people, or you know of people who are severely depressed, or who have, you think, more than just an acceptable reaction to tinnitus or hearing loss, the important thing is that they are made aware that there is help and that people are interested in helping them. It may not be perfect, but there is help available. And that help will only come if the decision is made to seek it and you walk in the door. Okay, So I'll just leave it there. No, thanks.
Let's have a couple of questions for Brendan, if you would, and then we'll have a little panel just to round off the day. Any specific questions about antidepressants and psychoses or whatever for Brendan? Yeah? You're frightened.
Too serious.
I'm surprised. If not, I'm going to just, can you help me get the chairs up? Oh, yeah, okay. We'll just do a final panel Sit down. So to round off today, we have our speakers. If you have any questions you'd like to answer, and then this will be the final session. Yes, John.
When you have a canal that's too small for CIC, don't you ask Bill to widen the canal so you can pop it in?
I would think this is a bit too extreme just for a hearing loss.
Wait, it's very easy to do. Bill, I'll show you how to do it.
Next question. The next. We're soon, there are some implantable hearing aids on the way, actually interesting enough. Needs a little bit more work on it, but I think the fully implantable hearing aids are around the corner. So, yeah.
Yes, I've got a couple of questions. Firstly, I know a little bit about electronics, and I've seen in a magazine, in fact I've got it here, an article how to make up a gadget that makes us hiss. It's quite a cheap sort of thing, and I thought I'd ask for a comment. If you'd like to comment on that, whether it's worthwhile or not. And also in the original article there was, I'll be quick, in the original article there was a mention that a cheap and easy way for the bloke in the bush, perhaps, was just to tune on your FM radio between the stations and get the hiss. The second question is a suggestion that maybe I'd like to see a verbal, perhaps a verbal of the particular types of tinnitus noise. And I've got a reason for saying this. And a second one, verbal, of approximately the levels. And the reason I say this is because it might be very, very helpful in talking and getting the message around to other people who think we're just stupid. Thank you.
Okay, before I introduce your first question, just Thelma's nodding at me, there is actually a disc which the Australian Tinnitus Association have of all the different tinnitus noises, and I'm sure if you contact the ATA office they can provide that for you. It's very interesting listening, and it certainly has been circulated around. So the other question I think was for Celene, was it, about using masking devices, and you were going to invent a masking device or make one.
No, it's an article in a magazine, Electronics Australia.
Okay. So would you like to make a comment on masking devices?
So what does this article say? What is it exactly, this device?
It's a simple device that makes the hissing sound, and some variations in the circuit for controlling the level and a particular type, a white noise device. And I'd just like to hear your comment on it. I'm not trying to be anti-professional or anything like that, but the article was produced in a well-known magazine that's been around the country, and a lot of people have made it. I haven't yet, but we'll see anyhow. Thank you.
Well, that's what a masker is. It's a noisemaker. Any type of noisemaker is a masker. So what you mentioned about the radio between stations, it's a very popular device that we give to patients as a first measure leave the radio between stations, you get the white noise, and that can help you to mask the tinnitus. The advantage of having the custom-made white noise generator is that it's a more comfortable way of walking around with that, because it fits in your ear properly, you won't be falling out or anything like that. But it's nothing more than a noisemaker.
I see in the Dick Smith catalogue they've just come out with something for $52.99 that is a radio, but it'll also give you different sounds like rain on the roof, surf, etc. And I looked at it and I thought, this is perfect for some people with tinnitus that find when they switch off the radio to go to sleep, their tinnitus increases. Thelma. Good. Very good. It's cheaper. How much is yours? Ah, there you are. Get the one from ATA. Actually, just listening to tapes, some people like those, you can get those Australian rainforest tapes and things, and they can be very soothing. When the noise is really driving you nuts, listen to some music. By the time you finish the music, the noise doesn't drive you nuts any longer. So it's just an easy thing to do.
It's Dr. Chen from Adelaide. I flew to Sydney this morning for this meeting and we'll fly back tonight. And it's very interesting to come to see this meeting today. And I'm very interested to see two times speakers mentioned about one of the therapy is using acupuncture, because I practice that technique and also see hundreds of people with these problems. I just think that because I notice a lot of participants or audience today themselves has the tinnitus problem, or they are the expert or practitioners. Just a little bit of few, I just want to make a comment, little bit of few tricks, very simple, may help a lot of people. I like to just use a couple of minutes. And first of all, acupuncture is helpful maybe for 30% people may get very good results, and 30% people may say get some result, and maybe 30% of people say no result. But before trying, you don't know which category you are in. And one of the very simple methods, because it's not practical to go to the acupuncturist to use the needle every day, but the acupuncture, the points you can use yourself, you can do for yourself very easily every day. One simple thing is when you open your mouth, you will notice two concave points, one in front of your earlobe, and another one is behind your earlobe. And you let like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Another 20 times in the morning, 20 times at night. Another way is like that way. 1, 2, 3, 4, 5, same 10 times, 20 times in the morning, 20 times at night. And the third one, put your palm here, use the finger. Something like that. In the morning and the night. And then last one, let's point in the top of the head and put this finger 1, 2, 3, 4, 5, 6, 7, 20 times in the morning, 20 times at night. This is a kind of acupoint that most of the tinnitus sufferers can do themselves every day. And some of my patients said after they do that, it immediately stops for some minutes, but later on start again. But the more often you do, it helps you and better. And also another thing is some people, when they put a finger in there, they feel the tinnitus even louder. But some people put a finger there, feel quiet here. Chinese medicine for many centuries explained that there's two different of tinnitus. One is the yin deficiency, the other is the yang deficiency. The herbal formulas are different. We have some over there at the counter, behind the counter. Thank you very much.
Okay, thanks. We'll all be. There you are. Brendan? Comment?
I have a question. A pragmatist, and if things work... Hello? I'm essentially a pragmatist, and if things work, they work. And I would disregard nothing that was useful to people, and I often describe it a bit like a smorgasbord. And out there at lunch, I noticed some blue vein cheese. I just can't eat that, so I left that. But I did eat some of the ham sandwiches.
Okay.
And quite a few, in fact. And so if that works for me, I'll use it.
Okay. Okay, he's got the microphone.
My question is to Professor O'Sullivan. You mentioned the treatment of depression and the relationship with tinnitus, and you talked about SSRIs. Do you find that SSRIs are more effective than the old tricyclics, or what's your opinion on the various types of medications available with regards to that?
Well, I don't know what your background is, but you know that most of this debate about which antidepressant is more effective is just pharmaceutical company blurb, that they all have a final common pathway, which is the same. And how they differ is in their side effect profile, not in their efficacy for depression. SSRIs really revolutionised the treatment of depression because they're very non-toxic and they're very effective. Whereas the old tricyclics like Crittenden, in overdose, which is an occupational hazard in this sort of game, they were very toxic, but they all work. And one of the problems with the SSRIs, of course, is that people have to say goodbye to their sex life, and most people don't like that. And tinnitus sufferers would be no different. So I've commonly used tricyclics because if there's a profound effect on libido. So it's a difference in side effect profile, not efficacy.
That's a big side effect. So.
My question is more of a general one, which has perhaps got a bit more relevance since we had the small discussion on the acupressure. Is it a Western society abomination, or does it exist at this level widely across the world? And most of the statistics we heard this morning were European type studies. Is there an absence of information from our Asian brothers or not?
You mean on acupuncture or electrotherapy?
I'm talking about the disease itself. Tinnitus itself. Is it worldwide spread? Is it a Western society thing or what?
Oh no! I think there's plenty of tinnitus in other countries other than Australia, and that's why acupuncture is used in China. It's interesting that there have been a few studies of acupuncture that have been a bit inconclusive, to be honest, in the Western world. And there is a lot of debate as to whether or not acupuncture is actually more efficacious in China. It seems to work better there than sometimes it seems to work here. Whether there's some mechanism in the brain which has to be involved in acupuncture being a success, I'm not sure. I don't know if any other panelists would like to comment, but there have been studies of acupuncture, definitely. I don't think there's any difference, but anybody know? I don't think there's a lot of difference. I think it's pretty widespread tinnitus. Okay.
I think at this point we should probably wind down the day. It's been, I found it a very full program and very informative. And one thing that I've myself taken out of the day is that the underlying message is positive. I know that there's help out there. I know that if I want assistance, there's assistance. And I know that technology does exist but is getting better in treating tinnitus. So if nothing else, if you take away that positive message, I think it's been a very rewarding day. I think the experience and knowledge that we've had in the lectures that they've given has been fantastic, to say nothing else. I'd like to say a few thank yous at this point, if I may. A couple of the companies that have sponsored the day or helped the day. Australian Communications Exchange, they were very generous in helping us with the videotaping of the sessions, and they will also be available at, from the ATA. Australian Hearing Services for the bags that were on the chairs, the printer call, and Tong Ren Tang for his support and assistance. So thank you. Also to Warwick from Laughing Partners, who, as you've probably seen today, is running around looking after the presentations and videotaping. I'd like to acknowledge various members of the ATA, and without their help this day really wouldn't exist. If I could ask them to stand. Thelma Hode. Paula, is Paula here? Paula O'Hare? Yep, yes, sorry, yes she is. And ATA's secretary and general hard-working girl, Deanne Irwin. Thank you. And of course, all of the volunteers that have helped with the food and the drink today, they've literally worked non-stop behind the scenes and just Trojans, basically. So thank you to those. And now for a special thank you to the lecturers today. On behalf of the ATA, thank you very much. If I could get Thelma to come up here. Thelma is the current Vice President and past President for many, many years. And Thelma will now give a little gift to show a token of our appreciation to the lecturers. John, would you like to come up here as well? Are there any other speakers I can't see who are still here? No. Okay. Phil, would you like to?
Encouragement from England, I think we're right, John? Yeah. And we're very happy, and John has been a wonderful support today.
Thank you, Thelma. If I can say one last word before I step down. In the year of the volunteer, I think it would be great if anyone out there would like to spend some time with us to help us, support us in any way. It would really help us help you. I'd like to ask Paula to come up and say a few words.
Frank has really stolen my thunder. I would like to thank the volunteers who have been with us today and who have done such a fantastic job. It's not an easy matter to organise things and then be on your feet all day, and none of us are getting any younger, so I wish we could get some younger volunteers. I don't know how they managed this at the Olympics or what incentives there were, but if there is anybody in the audience who thinks, well, that might be nice, I will ring the office and just see if I can be a volunteer or do anything. even to volunteer part-time if we have newsletters to get out and be folded. If we could just ring and say, well, are you doing anything next Wednesday? Could you come in and help us fold the newsletter? We would appreciate any help at all that's given. But we do have a fantastic band in the volunteers that we have. In fact, with us today is the first volunteer that Tinnitus ever had. Jan Lemens and Thelma. She was Thelma's first volunteer, and that was back in 1884. Beg your pardon. I'm sorry, Thelma. We'll amend that 100 years and make it 1984. So Jan is back with us again. In the meantime, she has lived overseas with her husband and reared a family and done all those wonderful things, and she's back with us again. So it's great to think, well, we have a volunteer that we can recycle. And it's a pity that we haven't got many more than we can recycle. Another thing I would like to mention, and I don't think we can mention enough, and Thelma has done it, Frank has done it, and I will do it again. Thank you to the professionals who help us. These are people who can command any amount of dollars, let's face it, they're worth it, but they give their time freely today. Now, Dr. Boustred, you may have seen a little girl sitting on the steps. Doctor had been to a basketball game, and he brought his daughter with him, and he was going back to the basketball game. And Dr. from Westmead, Dr. Carotta from Westmead, Doctor had to leave early because he had a football game on this afternoon. So they're family men, they're family ladies, they're family people. Celene's left her little girl at home with her husband, I imagine, today. So our professionals mean a great deal to us. They're there to answer any questions that you may have for us, and they're just wonderful people. So I would just like to say thank you once again to all of them.
I think that does it for the day. Thank you very much. And sorry, one last thing.
We do have just one more item to be taken care of, and I would like Kathy Challoner to come to the microphone, and she's going to just say a few words on behalf of our self-help groups who are with us today and who are sometimes very isolated in country areas. Thanks, Kathy.
Thank you, Paula, and thank you, Thelma, and thank you to ATA, because I too have a family life, and I'm a grandmother. I know I don't look it, but I am a grandmother. And normally on a Saturday and Sunday I mind my two grandchildren. And when I got the call from Thelma saying this, I'd seen this seminar I was going to be on, I thought, gee, I'd love to go to that, but there's only so many things you can do in a week. However, I was convinced on behalf of the support group from Tamworth, and which is in hiatus, that Thelma suggested that this would be a great opportunity for support group people to get together, feed off each other, work with the professionals, and also to get some enthusiasm and regenerate again to try and get the groups up and running. So on behalf of members of tinnitus support groups around, I'd really like to thank the ATA for assisting us in being here today. Now, one of the challenges which face support groups is sustainability. And keeping the momentum going is quite difficult, particularly when it happens to be part of what you do as a professional, but also getting the people to keep coming. However, support groups are just that. People come along, they get what they want, and they leave because that's what they've got. And that's good. We shouldn't ever expect people to stay and stay and stay if their needs are not being met. However, being at a seminar like this and getting a whole lot of new information, some of it confirming about what you already knew, but also confirming what you're doing is okay. It also provides a bit more stimulus for us to go back and encourage people to get the information, because without information you're ignorant, and when you're in that land of ignorance then you can't move forward and get on with life with tinnitus. And may I just say in closing that I'm a great believer. I've worked in noise injury for a long time, And I say noise injury rather than noise-induced hearing loss because the focus has changed from a noise-induced hearing loss to an actual noise injury. I too own tinnitus. It doesn't own me. And I'm trying to take the focus off tinnitus sufferers to a tinnitus owner. Thank you for the day. It's been wonderful, and I look forward to this evening.
Okay, on that note, I think last thank yous and enjoy the weekend. Thank you very much.